This is the first day of the Impact Workshop. And for this day, we'll have a physician and HTC focused session. It will last roughly 2 hours and will focus on barriers to care inside the treatment center and outside as we probe the question of how can we improve diversity in clinical trial and clinical treatment, as well as how can we address disparities in emergency room care. I'll be going over this in the video that I'll be showing, but the structure for today's workshop day is simple. We'll be showcasing the video. We encourage you all to type questions in the chat, discuss in the chat as you hear topics discussed, and to please feel free to discuss every topic that you feel is pertinent to the discussion. We'll have breaks for Q&A and discussion as we bring on the wonderful guest speakers, and really just hope that we can all learn something from each other. This is a learning workshop. It is part working group, part workshop, part community center. So we hope that we can learn from each other here and really share actionable solutions for increasing engagement and treatment for underserved communities. Thank you so much.
Hey guys, good afternoon. I'm Tammy Singleton. I'm a pediatric hematologist by training here in the New Orleans area. It's been a privilege to be a part of the bleeding disorders community now for many years. In the past year, I accepted an opportunity to be the Chief Science Officer at Athens. And so I'm really excited to still make meaningful contributions to care in this community. And I hope today that we have, I think, what we do best, and that is a meaningful, transparent exchange of ideas that we can, all move forward and utilize to do things in a much better way, and maybe make plans to have a call to action with some of the things that we discussed today. And I'm doing pretty good today here in New Orleans. It's a little hot and rainy, but excited to be here.
I can go next since I'm already unmuted.
Yeah.
I'm Jill Johnson. By training, I trained as an adult hematologist. I only see patients with bleeding disorders now. I see them in the Washington Center for Bleeding Disorders. And I also spend a lot of my time doing research to better understand the causes of bleeding and why people bleed a lot or a little, and complications of having a bleeding disorder. And the whole goal of that research is to improve the lives of people who are living with bleeding disorders. I'm also really looking forward to this opportunity. I want to thank HFA for putting these ideas together and getting everyone together to have important, I'm going to say probably also sometimes hard conversations about what have we done well and how to keep doing that, and then where can we do better, because there's lots of opportunity to do better, to do research that's meaningful for everybody.
I'm really excited. I'm excited about the weather outside today too. Right now it's like 70 degrees here, so that's awesome. That's a good start for me. And I might do some of this meeting outside, but I mean, this is, these kind of, I think, like Dr. Johnson mentioned, I think it's nice that we can have this forum to have those difficult conversations that, they're not always comfortable, but they're important to have. And hopefully we'll have a good, respectful dialogue regarding these issues. And, looking at the objectives and the goals of this, I started out, I'm a pediatric hematologist currently in Atlanta, Georgia, at Children's Healthcare of Atlanta. I've been around the country a little bit for my training, and so I feel like I've had some perspective on this. And my first clinical research was focused on trying to do a better job of taking care of women and girls and those with the potential to menstruate, really focusing on this community because I felt like it was an underserved group. And, it's not the only underserved group. There are a number of forgotten groups in here, and hopefully we'll identify and discuss these. There's lots of barriers that we can do something about as a community, and hopefully we'll have a good discussion about that and come up with some solutions.
Thank you so much. I really appreciate it, and having you all here. I think this is really going to be an amazing session, and I'm really excited to showcase the great work we did together. I'm now going to actually attempt to showcase the video that we recorded. Hi, everyone. Thank you so much for joining us for day one of Impact. Before we start, this conversation, I really wanted to just give a brief overview of today's event. We'll be starting out with a brief overview of the event and diving into some of the context of what led us to create the Impact workshop. Before heading into a panel on clinical treatment and clinical trial participation and how the complexities of clinical treatment and barriers to care affect clinical trial diversity for underserved communities. For day two, we'll be focused on member organizations and their work addressing underserved communities. And then finally, on day three, we will be breaking out into working groups to take the issues that we are discussing throughout the Impact workshop and break them down into actionable solutions. How can we take this wonderful group of individuals that we've gathered from member organizations to individuals from the bleeding disorder community to physicians and staff from HTCs and work together to come up with the solutions to address the issues that are affecting underserved communities and the bleeding disorder community as a whole? How can we work together to create the solutions needed? For this next section, I will be talking with the wonderful Dr. Tammy Singleton. Tammy, if you want to introduce yourself?
Oh yeah, sure. So I am a pediatric hematologist by training and education, and I am in the New Orleans area. I'm from Louisiana originally, and right now I'm very proud to serve as the Chief Science Officer for ATHN, the American Thrombosis and Hemostasis Network. I am still actively seeing patients in Louisiana, and I've been in the community now for a little while. Yeah.
No, definitely. Your work speaks for itself. Your presence in the community speaks for itself. I remember the first time we met in person, just being captivated by the presentation that you gave, specifically on underserved communities and access to treatment. Yeah.
I think this is a really important topic to have an opportunity to talk about.
Yeah, no, definitely. And, I think the fact that we secured $50,000 in funding to give out to member organizations that come to help support HCCs,
Yeah.
I think is really good because it's making sure that this isn't just any other workshop or event, this actually gets shit done.
Listen, it's so important. So,
Yeah.
I had an organization who gave me gift cards,
Yeah.
and they started out giving $150 gift cards, and then they started giving $300 gift
Yeah.
cards. I was like, gosh, that's a lot of money.
Yeah.
But I literally used them for families who I know were just struggling
Man.
to come to clinic. They didn't have gas money to feed the kids when they came.
Yeah.
So,
I tried doing that, but then Sanofi told me they couldn't.
and then there are all these rules,
Yeah.
right? And so there are rules and barriers to just really help people. So when I knew that there was a patient who was struggling, just to get to clinic, or if someone would say, well, I can't get there, we would ask them why.
Yeah.
Well, what can we do? And if they said, well, we just don't have money to, put gas in the car to drive there because it's a 2-hour drive.
Yeah.
Well, we have cards, that you can use to get gas and maybe get some food for the kids, on your way back. Would that help you to get to clinic?
Yeah.
We would also do things like if we knew there were 2 sisters and the sisters each had, a kid with hemophilia.
Yeah.
They would try to ride together, and so we would try to make sure we accommodated them
Yeah.
in getting to clinic, on that day. When I knew there was a patient coming and they were struggling to get there, I never turned a patient away.
Yeah.
If you're late, you're here.
Yeah.
Thank you for coming, right?
Yeah.
If it was the end of the day and I would ask the staff, hey, can you stay?
Yeah.
They're struggling, they need to get here. What can we do? And it's about just having a real approach to people. That's one of the things that the hemophilia treatment centers do best, I think. And there's some non-federally funded hemophilia treatment centers that have that same standard. But you can't tell me that a patient who's going to an office where there's a primary
doc who's an oncologist
Yeah.
who is seeing some of these very rare disorder patients who really need a specialized approach, they're kind of falling through the cracks.
Yeah.
And they're not really having an opportunity to have really great care, not just care,
Yeah.
but great care.
Holistic care.
Holistic care, access to the best that we have to offer. They don't have access to that. They also don't have access to clinical trials that could be life-changing for them, right? You participate in a clinical trial, it's life-changing on a number of different levels. And I'm a clinical trial participant myself, so I can say firsthand, like it's, I try to have my children have an opportunity to participate in a clinical trial. And what they communicated back to me, which I thought was so awesome, because they were kids when they did it. They said, you know what, I know that this could possibly help me, and I'm interested in that, but it feels good to know that it can help other people too.
Yeah.
And, you know, that's a great feeling, to feel validated, to feel needed, to help other people, and to have a sense of empowerment to help yourself. And when someone's explaining what a clinical trial is to you, it's your choice.
Yeah.
So I think it's so empowering to sit in that position, have someone explain what this option is that you could participate in, and you're making the decision, right, to participate in it or not. And when you're not at an HTC, or when you're not at a center that offers that type of care, you just don't have the opportunity.
Yeah, and that's why in this in the conversations that will come, I think the real focus is on labeling healthcare systems and healthcare systems as a whole, because so often we talk about, we think of it as, visiting your primary care provider, visiting an HTC, visiting, a hospital. But it's not just, like you said, it's not just a hospital.
No.
It's holistic. It's
totally holistic. And one of my favorite things to do when I'm in comprehensive clinic is I like when the social worker, nurse, and everybody else can go in before me. And I'm like, okay, what's the scoop? Tell me, what's going on. Everyone has different information. You may ask the same question, you get a different answer. Well, that's not what he told me. What did he say to you? And we kind of piece it together. And it helps me to understand if I want to provide some information or education, if I want to try to really help the patient to know what's going on, right? What's happening in real life for you before I can go in and propose something that's completely unrealistic. It's not going to work for you at all. Sometimes when we talk about adherence, talking about you keeping up with the therapy, I'm like, okay, listen, let's be real. I don't take my medicine every day. I want to. I intend to. I'm doing everything I can to make sure I do it. I set alarms. I have it in different locations. But the reality is, there are times I don't do it. Or there's a time I'm like, did I do it? Why don't I do it again? Well, and you're doing your best. So to kind of talk about or have someone not shame you, right? Or you not feel ashamed to say, yeah, I know I'm supposed to do it, but sometimes I struggle. And maybe even to talk about what that struggle is, I may have some suggestions that could really help you to overcome it. If I ask you the question, hey, listen, I miss my meds all the time. How often are you missing? Do you have any issues? Like, is it difficult to remember? If you approach someone in that way, you may actually get like the right answer. Well, Dr. Singleton, I really only use that injection about every 10 to 14 days. Well, if I was sitting here with the assumption that you were actually doing it every week, that's not serving you well,
Yeah.
right? And if you felt that you couldn't say that,
Yeah.
I mean, think about it. When you go to your primary care physician, don't you feel like you're on the clock? Like you're kind of like on a stage a little bit. Like there are things you want to say, you forget to say them. You're trying to get it all in. Sometimes you feel that they are kind of pressed for time. And so that can be a little awkward if you don't know how to manage that. But it shouldn't be on the burden. The burden should be on the patient, like to manage that. One of the advantages and what's so cool about being a hematologist in this community is I always say I can walk in, sit down, and cross my legs. And I can look at you and go, okay, what's up?
Yeah. You know, that's why I look for my primary care provider.
Yeah.
He is a man who is a Middle East citizen.
Yeah.
And I know that he is going to tell me exactly what I should be doing. He's going to tell me, we've got that relationship where he will actually call me out.
Well, you know what? You just hit on something.
Yeah.
Relationship.
Yeah.
Think about it. There are so many people that do not have a real relationship. Right? My OBGYN, she completes my sentences.
Yeah.
You know, I say, oh, I'm concerned about such and such. She goes, oh. And she knows my story, my background. She totally completes my sentences. When you have a relationship with your provider, you automatically have better care. Think about again the average person. Do they go to a provider that they have a relationship with? Do you feel comfortable with that provider? Do you see them enough? Do they know you? Do you connect? Do you understand that if you go to a provider and you don't have that relationship, that you have the right to find one that you can have that relationship with? So many people interact with the healthcare system in a way that they don't expect it, they don't understand it. And a really good example, I would even talk about, like, I had one parent who did really well with understanding, having a relationship with the provider. But my mom interacted with and interfaced with providers in the healthcare system in a completely different way. And so even when you have access, you know, you have insurance coverage, you can pay for your medications, you have transportation to get there. Sometimes from a cultural or historical perspective, you just interact with and interface with the healthcare system differently. And if you don't have providers who will kind of embrace you and bring it to you, you never have an opportunity to really have that relationship.
No, 100%. When I walk into my clinic, I hug my doctor. He, when he's recommending testing and I get a little bit worked up, he knows to say, hey man, it's okay. This is not going to help. This is what's happening to you right now. I know you. We talked. I know your full history.
That's right.
And it's that relationship. But I think about impact, and I think about what we're trying to do with it, and it hits on the crux of what the purpose of the workshop is, and it's how can we solve these complex issues of healthcare access and research enrollment in a way that's programmatic, in a way that's policy focused, in a way that takes all those complexities of being a person and boils them down into the complexities of solutions, which isn't easy. And hopefully through the program we can give people the necessary tools, information to take this back to their own HTCs, to work with member organizations, to reach community members. But if you had to think of a way of how we can change how we solve things, I guess it's it's a very hard kind of question, and it's a lot of burden, we asking you right now. But if we think of how things have been done in the past, if we think about the workshops and webinars that have come before us that are the ones we all attend, and we think of what happens after, you know, sometimes there is a sense of disappointment
Yeah.
because nothing changes.
Mm-hmm.
And there's a want for things to change. There's a want for, you know, meetings to matter, for, you know, resources to matter, because we're dealing with finite resources.
Mm-hmm.
You know, and looking at these solutions, how can we make the meetings that we're having actually matter, so that when we put this great event together to bring member organizations and physicians together from across the country,
Mm-hmm.
that the solutions they talk about actually come into reality?
You know, I think to start, I think that in the hemophilia community, we have to really stop and reflect and give credit where credit is due first, right? I think in looking across even just the other conditions that I treat, this community is pretty powerful.
Yeah.
And educated.
Yeah.
In terms of what's happening with you,
Yeah.
right? And the advocacy is second to none.
Yeah.
Right? And the power that you have in that, and the change that has been put in place because of that, is just amazing.
Yeah.
So I think that in just taking a look at yourselves, and going, you know what, we're pretty good at what we do.
Yeah.
Like, this is, we're really making it happen.
Yeah.
And having people just stop and soak that in for a second, when you understand your own potential and your own power and your own worth, I think you can almost do anything.
Yeah.
So I think just giving yourself grace and credit, you know, first is probably a really great place to start. You know, even going back to, I'm proud of my age, you know, so, but Ryan White and I are we're the same age.
Wow.
I'm 2 weeks older.
Wow.
And when I think about what he was going through, I remember it. It was being televised.
Yeah.
He was a powerful kid.
Yeah.
And I'm sure that his mother is even proud today of what he has changed, what he did to change the world.
Yeah.
Right? Not just with hemophilia, right? But with people who were suffering with HIV, AIDS, it really changed the world. So I think, again, I know it's a long-winded answer for that just first part, but I think it's important to just first stop and give yourself credit. Secondly, I think something that's just kind of relatively simple, you know, asking yourselves, what do we want to accomplish?
Yeah, that is a good question.
And be specific.
Yeah, be specific
But
about the solutions we want to
Be
accomplish.
specific. Like, list out, like, if we were to list 10 things right now, like, what do we want to accomplish?
Yeah.
Write them down. Remember them. Don't just talk. Circle back. Did we do it? Was it done? Okay, we did 2 out of the 10. We did 1 out of the 10. Like, well, what are we going to work on now? And how do we really address the problem?
Yeah.
I think that it is the craziest thing in the world to talk about barriers to care, and I'm not getting the answers from a patient. I think that that's crazy.
Yeah.
If you think about it, I'm
Yeah.
like, why do I want to sit around and talk to my colleagues
Yeah.
about the barriers to care? We don't have the barriers.
Yeah.
We're not experiencing the barriers. What did your patient tell you? What about that person that you haven't seen in a long time? Do you know why? You haven't seen them? Some of the mild hemophilia patients were told for years they didn't need to come. Do you wonder why you don't see them? You were taught you didn't need to come here. Well, if now we're changing that philosophy and that mindset, well, exactly how are they gonna? How do you shift? Right? you're now 40 years old and you need 3 joints replaced because you're a person living with mild hemophilia, you were having issues. For years as a community, you know, we didn't really emphasize it or address it. Now we recognize the importance of it. How do we address that person?
Yeah.
How do we address the mother and father of the 5-year-old who has mild hemophilia? You know, they're two different groups, right?
Yeah.
Women living with hemophilia and bleeding disorders, I'm ashamed of the way that we just didn't even think about it.
Yeah.
I'm still, you know, a little clutching my pearls now with the way that we approach it. I think you fix it, you address it by asking the people who are experiencing it what some of the real issues are.
Yeah.
Now, then how do you accomplish it? Like, how do you make it an action item? How do you change it? Well, that's when you start talking to other folks, right? That's when you start talking to the people in the healthcare systems. And I want to point out that the healthcare system is not us. We let go of that healthcare system a long time ago.
Yeah.
You know, we're impacted by the system too.
Yeah.
And it sucks.
Yeah.
You like to use that word.
If you've ever been on an airplane and airport, you've actually seen pilots go up to the checkout desk to get their ticket to actually be the pilot. It's similar to that. Most people assume the front desk people and the pilot are working on the same team,
No,
but they're not.
We're not.
Yeah.
Right. So it's about figuring out like how to make a difference. You know, I went with the American Society of Hematology. We had this workshop, which was wonderful, to learn how to be advocates. You know, to go and lobby to understand the issues. And I just sat there wondering to myself, right? All day we went to visit our senators and our, you know, represent our congressmen, and I'm sitting there talking to your, you know, 28-year-old aide, who I know is a very important person in your office, but are the issues really going to be addressed?
Yeah.
You know, does it really, like, how do you really, you know, create change?
Yeah.
And so that's where I think some of the organizations where your power is, because you know that part, right? The power is you know that part, and showing up collectively and showing up together and using your resources and the history and the things that you've experienced and the people you know, you can make it happen. And it's not going to be huge change at one time.
Yeah.
You know, what's the story of, like, how do you save the story of the starfish on the beach? You know, when there's millions, you know, on the beach. What do? You just chunk one back into the ocean, you know, one at a time, right, as you can. And so one of the things I think is beautiful as I've been on this journey of treating patients, I may not be able to change the entire community, but I can change the world one kid at a time, one person at a time.
Yeah, and I think, you know, looking at the actual event that we have ahead of us, and looking at, you know, day 2, where we have, you know, we're focused on member organizations sharing the actual outreach work that they're doing, you know, and the unique opportunity that we have in, you know, having physicians from HCCs, having, you know, care providers from HCCs and patients and member organizations in the same room to talk about these issues. It lets us write down that list, those top 10 things we want to change. And, you know, we go into day 3, our workshop day, where we actually break out into groups focused on issues and we discuss these things. You know, I hope that everyone comes on day 3 with that top 10 list of things they want to change.
That's right. And action items, right? And action items. Like, what can we do? And you may not accomplish all of them.
Yeah.
But some of them.
Yeah.
And be a part of, you know, be a part of the solution, you know, and not a part of the problem. And it's okay to complain, but I think you should always ask, well, how can I make it different?
You know, I think, and this might, you know, seem off topic, but I think one of the worst things about policy solutions is that sometimes they get buried underneath clunky names that ignore what they actually are.
Right.
You know, if we look at like the policy, solution PDUFA, it
Mhm.
was a policy solution created in the wake of, the AIDS movement,
Mhm.
of the bad blood crisis,
Mhm.
of the advocacy work done in the wake of the AIDS epidemic, specifically to bring in the patient voice and to fund research into novel treatments.
Mhm.
And PDUFA, it means that once a drug is submitted for approval, part of the money from that approval process goes into funding new treatments. And the fact that, we have such a long name that, complicates it, that, makes it anonymous, that takes its meaning out of it, to me, I think is one of the negative parts of policy solutions.
Yeah.
Because it's not PDUFA.
Mm-hmm.
We shouldn't think of it as, this long acronym that sounds funny when you say it out loud. We should think of it as a system by which drug companies are directly funding new research by submitting novel treatments.
Right.
And that was fought for by individuals from the bleeding disorder community. That was fought for by advocacy. That was fought for with people's lives, and it was achieved.
That's right.
And we should think of that way. We should think of it in a way where we're looking at these solutions that we're coming up with, not as policy solutions to be made into acronyms, but as real impacts on people's lives.
Yeah.
I hope looking at the next 2 days that we can actually, really see these things come through. That we can all arrive out there on day 3 and have that top 10 list, like you said. That we can go into that day and each person, the dozens of people attending this event, can each bring together their own policy priorities.
Right.
And we can action plan it, and we can use, the resources available to us, the wonderful member organizations, the terrific HCC staff, and we can help advocate, like you said.
That's right. That's right. And I also think that, if we collectively, in the HTCs and with our advocacy organizations, almost have a campaign where we focus on the people that we don't see.
Mm-hmm. Yeah.
Yeah. How can we, really reach out to the people who are in the community who are hurting the most, who are silent, who need the support.
Yeah. The individuals who have fallen through the cracks.
That's right.
Yeah.
Like how do you reach those people to ask the questions?
Yeah.
What are you experiencing?
Mm-hmm.
Why are you not here?
Mm-hmm.
Just trying to figure it out.
No, definitely.
Yeah, I think it really makes a difference.
Yeah. Addressing the unaffiliated individuals who maybe have, like you said, the milds who may not return for treatment.
They were told not to.
Yeah.
For years, like they were told, you'll be fine. You don't have to come.
Yeah. Or the women with bleeding disorders who were told they didn't have a condition.
That's right. Who are still told, right, that they don't.
Yeah.
That they don't have a condition.
Yeah.
Yeah.
Or maybe the community members from communities that non-white communities may think that hemophilia is a disease that's not affect them.
That's correct. That's correct. Yeah. So I think that so much progress is made all the time, but the only way you continue to improve is to continue to ask the questions.
Yeah.
Like how, as we're doing now, right? Talking about what some of the barriers are, but asking, I think you have to, again, not to be repetitive, but I think you have to ask the right person the right question.
Yeah. Yeah.
It all depends on how you ask it too.
Yeah. No, definitely.
Yeah.
No, definitely. But I think asking it together, I think we find a solution that way.
I think so too. So tell me impact.
Yeah. The goal of impact is to be different from the other workshops. It's to be different than the webinars. It's to do something different. It's to provide funding for individuals who attend. It's to say you attended, you got resources, you got material, you got information. Here's some additional funding also to help make sure that you can actually follow through on this.
Yep. I think it's also really, it's asking the right people.
Yeah.
The right questions.
Yeah.
Yeah, that's what you're doing.
And we're also making sure, like you said, we're not asking just one group of individuals to talk about barriers to care. We're not just asking physicians, and we're not just asking, patients. In so many of these meetings that we have, and so many of these like workshops we're in, it's separated.
Right.
We have physician-only councils, meetings, working groups. We have patient-only working groups. We have patients who are part of, FDA-funded roundtables, discussing novel treatments, and we have physicians part of, programs for NIH. We have to bring them together in one place, and with Impact, we can do that. We can take this long acronym workshop, and we can do something that, hopefully should be done more. And it's not the first of its type, and hopefully it can be not the last. Hopefully we can have future events, and not just HFA. HFA will continue the work of bringing together, major stakeholders, but maybe also other organizations can see, this idea of not only having programs, but having programs that make a lasting, pardon the pun, impact.
Right. Well, I think too, it will be an opportunity to have people come together
Yes.
that are largely absent.
Yeah.
For example, in clinical trials in large numbers.
Yeah.
And to ask the question, well, why is that?
Yeah.
Like, when you hear the words clinical trial, like, what do you think? Well, like, what does that mean, to you? So to be able to ask those questions, right?
100%, yeah.
Yeah. What is a clinical trial?
Yeah.
Have you ever been offered an opportunity to participate in one? And when it happened, like, what was your experience? Did you understand, like, what was being presented to you? Were you confused by it? Was it a bad day? Do you think some of the words that were used were, difficult to understand? Were you fearful of it? So I think asking some of those questions about clinical trial involvement and just your knowledge of it in general, with those people who are largely absent, but who ultimately use the therapies, which is so important, right? To be represented, to understand what happens. You ultimately use those therapies. But in terms of it being studied in larger populations, it doesn't always happen.
Yeah.
Yeah.
No, definitely. It's such an important conversation.
Very important conversation. I was talking to, it was like a friend of a friend, and we were in a group setting, like a book review. And the book was about a woman who participated in clinical trials. And one of the people there, her daughter had breast cancer and ultimately, passed away from breast cancer. And when I explained to the group what a clinical trial was and the different phases of clinical trials and what happens in phase 1, phase 2, phase 3, and then ultimately drug approval, she looked at me and she said, we were offered an opportunity to participate in a clinical trial. And while I know it may not have changed, my daughter's ultimate course, I think we both would have felt good participating in the study if it was explained to us in a way that we understood it. And there was a language barrier with the words, I think, that were being used as the trial was being presented to them. And your default, I think, for all of us, when you don't understand something or when you're fearful of it, is to say no.
No. And it goes back to the idea of trust, and it goes back to the idea of communication and different individuals getting different things out of their healthcare systems.
Well, trust is huge, right? Because trust is also about relationships.
Yeah.
So if you have a true relationship with your provider and they're presenting a clinical trial, at least the level of trust is there to be able to kind of take in the information. So sometimes trust is a huge thing, which is why I think we have to address some things up front. I think you heard me talk about when I speak to a lot of patients who are from Black families, I'll go, I know that you know about the Tuskegee experiment. So I want to explain to you some of the changes that were put in place after some of those atrocities happened, you know, in the last century. And I'll go through and explain the protections for humans participating in clinical research. And I think when you explain that up front, that at least eliminates the anxiety associated with some lack of trust, especially in that particular community. But then you would need to know that and have sensitivities, those cultural sensitivities, right, across the board. So I'm so glad that this conference is taking place, because they're very important conversations, I think, that need to be held so that you can really find out what some of the true concerns are, what some of the barriers are, and make your top 10 list to try to eliminate them.
No, I'm so excited to go through all the panels that we have, and go through not just impact but also what comes after. Because
Right.
I think that's really the most important part, because impact doesn't stop on the last day.
And that, I think, is going to be the key.
Yeah.
Like the question you were asking earlier, like, how do you really create change? I think it's with that follow through and follow up.
Yeah, no, 100%.
Yeah.
No, thank you so much.
Absolutely.
Amazing. Thank you, everyone, again for bearing with us through those technical difficulties. As we just heard an amazing introductory conversation with Dr. Tammy Singleton on what the meaning of change is and how we can all affect it, and the importance of this meeting and coming together to make sure that the solutions we come up with are, really contextualized, not in, policy wonkiness or in far off concepts, but in realistic policy and programmatic solutions that impact people's lives, and also the people and lived experiences that make these solutions necessary. The whole purpose of impact was really to put a human face on an issue and come together in a way where we can brainstorm, conceptualize ideas, and work together to really make to make sure that the underserved communities, that bleeding disorder community members are, engaged with in a way that's respectful and that pays heed to their needs in both care, in clinical trials, and in treatment. For this, we'll be going into a Q&A discussion with Dr. Tammy Singleton, Dr. Robert Sidonio, and Dr. Jill Johnson as a brief intermission. We hope we can all talk. If you're able to come off of camera, you can either request that you're unmuted or type your question in the chat, and we can do our best to have a good conversation on the topic of health equity for the bleeding disorder community. I also wanted to note that while today is largely pre-taped in terms of the content, the following 2 days will be largely more focused on Zoom meetings and workshop and working groups. So there'll be no tape content for them. Again, thank you so much. If you want to do instruction, we already did it. You know what? We can just go into it. Thank you so much for coming. I'd love to just honestly know what your first thoughts are, Dr. Sidonio, on seeing that conversation with Tammy. Your thoughts on, the idea of the top 10 list, on the idea of, making those policy changes real.
Yeah, I mean, I think, yeah, thanks. That was nice. I know we didn't record at the same time, so I didn't get to see it the first time. And so, yeah, I mean, I think a lot of us are in line or we wouldn't be here, having this conversation. I like the discussion we have about inclusion and research, making sure that we're considering all these things. I mean, Tammy covered a number of topics, obviously. And a lot of the issues with inequity and, sort of the basics of trying to get a patient into clinic, right? I think that's part of the problem. We are so focused. I was talking to somebody today about adherence to therapy and all this stuff. And then, finding out that the patients, recently parents just got divorced and they're having to go across town with their family. And one of the kids was really upset because he was sleeping on the floor and felt like he was really afraid of the bugs that were in this apartment. So it's just like things we aren't thinking of these things. And of course, that is not going to be an atmosphere for somebody to receive the optimal therapy. And we're really thankful. I think the model that we have in our clinic is very useful because our social worker, a lot of people are interacting with patients, whether it's in person or in virtual, and we all have our role in getting these things out. And oftentimes, every week we say this, oh, parents' mom never mentioned that to me. Oh, or dad never said that to me. I say that every week, every week I'm like, oh, I didn't know about that. And so I think it's helpful to have all these different layers. It's helpful to have, a diverse staff as well. We recently hired one of our nurses who is medical training in Spanish speaking, and it's been very different. I feel like it's been much better the way that we communicate with patients that are predominantly Spanish speaking, because we actually did hear from our families. It was hard to hear that they felt like we weren't spending as much time, we weren't engaged, maybe weren't engaging as much, and the practicalities of it, you have the same amount of time for a Spanish speaking patient as you have for someone that speaks English. And so it's hard. And so you're really trying to do your best. It's not like we're trying to not do our best. We're trying our best. So I think it's helpful to get that perspective. And so everything else, that Tammy said, we 100% agree with. We align on most things together. So they're like sports teams, things like that. Otherwise, we're pretty closely aligned. So.
And Jill, what are your thoughts? And I know you've got to have some thoughts seeing the just so everyone knows on the call, the day of filming that we had in San Diego was intense. We had Dr. Sidonio, Dr. Singleton, and Dr. Johnson in a hotel room at 4 a.m. and it was like a special operation. It was incredibly just a hell of a performance. It took 5 hours, maybe 6 hours of straight filming. And we really got into the nitty gritty. There's so much film that will not be being shown, but just so many great conversations. I'm especially interested in that point about Miles being told to, avoid treatment or not needing to come back in. I think that really, really stuck with me.
Yeah. So, I'm mostly going to be echoing what everybody's already said. So I think I'll try to emphasize what I think is most important is that we're all here with good intentions to try and make things better for people. And even when the details are different, the themes seem very similar. The themes are very similar. If someone is disenfranchised from their healthcare, the details of why are probably different, but the themes are there. It may not be specifically Spanish, but it could be language. It could be culture barriers. It could be acute events, social disrupting events at home. And the barriers to healthcare are also the barriers to research and getting the evidence we need to deliver better healthcare. And it can end up in this vicious cycle where the people who are having trouble accessing the system are the ones where we're not getting the evidence to make their lives better. And we kind of end up in this loop that we all would like to break. And it is a relationship. I think Tammy made that point very well. And I think we're echoing that with, I guess I should use last names. Dr. Singleton made that point very well. And Dr. Sidonio echoed that these are relationships with people living with the disorder, the people who care for the people living with the disorder, the people on the care team, which is not just doctors, not just nurses, it's everyone. And all of these relationships need the more functional we are, the better this is all going to go. And we all need to understand that we're probably delivering some imperfect version of that. And it's not through bad intention. We want to make it better. If we could make our visits longer, we would. If we could go out into the community so people don't have to travel, we would. If we could have a weekend clinic so that people who are employed but not employed in a way that they have control over their hours, we would. These are all things that we would wish we could do better. So I think using technology is potentially one way to make things better, like we're doing right now. We would have a hard time getting everyone together. So thank you for doing all this filming, and thanks for putting this effort together.
Yeah, can I add, and I think it's important that we try different things. So I remember when I was starting a first women's clinic when I was at Vanderbilt, and we were trying to figure out how can we get better attendance, how can we try to get some of the patients that were struggling to get in. So we arranged for it to stay late to see, well, maybe we can get people that are coming off of work. We even did a weekend one, which was not very popular with my nurses initially on this. Both of these didn't really seem to work or move the needle, but the point is that we were trying different things, and it may have worked in a different scenario in a different location. Maybe it would have worked. But we kept trying different things, changing the days and asking patients when does it work best. So I think you just have to keep trying, and can't be afraid to fail on these things because believe me, I heard it a lot when the weekend thing didn't work. So I was like, yeah, we told you this wasn't going to work. I heard that a lot, and I said, well, we have to keep trying. That's what we're doing. We're otherwise we're just the status quo, and nothing's going to get better. Like Tammy was saying, nothing's going to change, and so we have to try. So
Thank you so much. I mean, honestly, I think the biggest thing I'm excited for the next, 2 days of impact and including today is all of the just trying we can do, all the solutions we can come up with, all the, fight that we can really, start or continue. Really with this unique space that we have HCC staff from across the country. We have you amazing guest speakers and, presenters on the call. We have amazing member organization EDs. We can really do something special here and come up with, solutions that pay, heed to the actual lived experiences of the participants and maybe think of a new and better way of addressing solutions. I'm really excited for the next session. We're going to see Tammy and Jill again, this time focusing together on a panel to discuss issues of health equity in clinical treatment. So, without further ado, I'd love to kick it over to our video manager to start the video, and we can get into it. Thank you so much.
We're really excited to be joined by Dr. Jill Johnson from Washington to help lay down the groundwork for our next panel that will focus on barriers to clinical trial diversity and clinical treatment. Jill, if you want to introduce yourself really briefly.
Sure. I'm Jill Johnson. I'm an adult hematologist, and I also do a lot of research in the genetics of bleeding disorders.
Thank you so much. We're really excited to have you here and really focus, on starting impact in a way that focuses on the complexity of the bleeding disorder community and the members that comprise it. And that can be in a multitude of different ways, especially when we're talking about health disparities and the different factors that play into communities and their access to care. The very specific lens we're taking today is the lens of clinical treatment and its impact on clinical trial diversity. So I'd really love to start by talking about barriers to care and how they affect healthcare system access for sections of the bleeding disorder community. When thinking about your Washington patient population, the community that you treat, are there sections of it that have difficulty accessing care?
Yeah, I think the state of Washington probably is a microcosm of the entire United States. We don't have the same balance of populations, but I think we see so many barriers to getting to care. So we have both urban and rural populations. We have Native American and First Nations people. We have people who are immigrants who are sometimes undocumented. We have the lay of different kinds of rural America. And we have people who range from, unhoused to very wealthy. And it's true in our system that when people have advantages, they have an easier time getting to health care. And every time you add one disadvantage, it gets that much harder.
Oh, yeah. You know, when discussing clinical treatment, clinical trial diversity, oftentimes we place them into different buckets. We place them into different buckets. And when we discuss policy solutions or programmatic solutions, we think of, you know, what can improve access to care, what can improve, you know, the research gap. I'd love to hear your perspective on the research gap and what that really means for underserved communities, especially in the bleeding disorder community.
Yeah, well, I think first it's important to know that bleeding disorders, for the most part, hit everybody. So that means all the disparities impact the bleeding disorder community because essentially everyone could have a bleeding disorder. And the other piece of it is in order to know that someone's not being represented, the system has to be aware. And so if the system, there's definitely, I think, you can be so marginalized the system doesn't even recognize that you're not engaged. So it really can run the gamut. In research, if we didn't know about you from healthcare, then we don't know what to put into research. So if the voice isn't there and the need isn't recognized, then the research also doesn't know to ask the question. So it's also, as you mentioned, buckets. Buckets are important to acknowledge because as a system, you gotta make categories and describe what you want to do. But each person comes as their own person, and they are complex, and there's many things to each one person. So I think it's important to merge, like, how do you categorize things, and to recognize that that's a really simple way to approach what a person is.
Yeah, no, we have to address the complexity of people to address the complexity of the system.
Yeah, exactly.
No, I think that's so great. And centering people at the center of these discussions and the uniqueness that makes up people is such a brilliant way of looking at it. No, thank you for that. I guess looking at your specific community, can you think of an instance where certain individuals or subsections of the community faced a specific barrier that was tied to their specific group? So, say for example, you mentioned First Nation individuals.
Mm-hmm. Yeah, I mean, I'll give an example. During the COVID-19 pandemic, we started using telemedicine in a way we hadn't used before, and it really opened up access to lots of communities we hadn't really seen. And our clinic engaged with people that had never made it to an HTC before, but there were exceptions, and one of them was you have to have really good internet and really good access to data, and that wasn't always true. So people would have to travel to like their uncle's house. It was actually not providing them the access that everyone else was getting from telemedicine. Mm-hmm. The other part is there's a justified lack of trust of the healthcare system because it's been broken a lot. Mm-hmm. And so I, as a person, want to do the best I can for my patient, but I also know that I'm in a system that has been unfair in the past, and I understand that that trust is broken. And so as an individual, I can work to gain that trust, but sometimes the trust barrier is so great that why are they coming to that clinic in the first place? So we work with a family and recognize that not everyone's gonna come all the time. And when we just try to open the door to be welcoming and explain how it works in our system, but it is a really challenging thing, especially with medical trauma. Everyone interacts with the healthcare system enough. You're gonna have a bad experience. And if you've already had a bunch of other bad experiences, why are you coming back?
And trust is the center of the consenting, the clinical research process.
Yeah, it's a big deal. It's a big deal that the system has these flaws, and that the biases are there, and we all have these biases. I have biases. Everyone has biases, and we need to find a way that it's a safe space to come to, and for healthcare, and then because the engagement is there, then there's the opportunity to also offer research. But we have to, as researchers, be transparent and accountable and view the research as a joint activity with the people that are participating.
Oh, thank you so much. I think it's such an incredible point. And I can't wait to discuss it in our full panel as we move on to the next section. For this next part, we'll be joined by panelists Robert Sidonio and Tammy Singleton. Robert Sidonio is, of course, hailing from Emory, while Tammy is representing Athens today. And we can't wait to have you listen to this incredible panel on clinical treatment and clinical trial diversity. Thank you so much for joining us for this panel. I wanted to start out by just laying the groundwork. We talked with Jill earlier about the complexity of the person and how it impacts healthcare systems, and how to address them. We have to address all of the different barriers to care individuals face, the different realities, in order to address the issues. And hopefully through impact we can do that all together, and beyond impact, of course.
Mm-hmm.
But looking at the issue of clinical treatment and the impacts that it may have on the research gap for underserved communities, we know that research directly informs clinical treatment practices. It informs novel treatments. I'd love to talk with you all about the issue of clinical trial diversity and clinical research, as well as clinical treatment, and how they play into one another in the healthcare system for underserved communities. We know that research informs practices, it informs treatment, it informs so much of the healthcare system, and yet the healthcare system also informs research. It also informs the gaps that exist therein. So looking at the community that you worked with as a pediatric hematologist in Louisiana, Tammy, I wanted to start off this conversation by asking you if there were certain complexities in your state that directly impacted individuals' access to healthcare.
Oh my gosh, yeah. So we talked a little bit about these things before, and I think I probably want to start off, well, I'm a pediatric hematologist, but I treat both children and adults with bleeding, clotting disorders, other rare conditions. And the first thing that I sort of want to say is when you use those buzzwords, diversity, underserved, barriers, in this country, we think race.
Yes.
Like you go immediately to Black people, white people, and it's not that at all. What I think we're really talking about, to try to illustrate it, there are people who are incredibly hard working people who have made tremendous sacrifices, who may be self-employed, they may be entrepreneurs, very successful, I have a brother who's a plumber, very successful plumbers or plumbing contractors of the world who really don't have access to healthcare because of the cost. And, when you're employed and you have access to really great insurance, you don't have a clue what it's like to not have that. And so I think that thinking about how diverse we are, to use that buzzword, meaning how different we are, the different walks of life that we come from, the mother who's at home taking care of her child who has a chronic health condition like hemophilia or others, right, can't necessarily have a full-time job. Maybe there's a dad who's at home who's caring for his wife. So we have a very diverse community in terms of access to care. I was at Tulane University School of Medicine for a really long time. I was raised medically, my adult life in New Orleans, in that community. And I always said this is amazing healthcare in our state. And people have access, to this. You can come to New Orleans. Never thinking what it was like for someone who had to use Medicaid transportation to drive 40 miles into the city, wake up at 2 o'clock in the morning to even catch the van, to get there, to come just 40 miles to get to that 8 o'clock appointment, miss a whole day of work, maybe have to find money to pay a babysitter. And those types of barriers that we don't really think about, that's really impacting what we're doing. It's not only impacting clinical care, it's for sure impacting research, right? So how could you possibly process or think about what research is, trust participating in it, if you have difficulty just getting to the appointment for regular care? There are so many other issues. Getting then to the next place to get your medication. You get there, there's an error. How do you contact and communicate with the healthcare system after that? So I think we have to really reframe how we think about barriers, diversity, and really understand what people are experiencing in order to make a difference.
No, definitely. Yeah. No, and before we go, I'd love to hear Jill's response to that. I think one an issue is, like you said, these jargony words. We think of in the policy sphere as direct and indirect costs. We think of it as burden of care, burden of disease, burden of condition, economic burden. And these are terms that oftentimes don't resonate with the average individual when discussing these very real impacts. While we can bucket it in some ways by getting more jargony and getting more specific, we end up stripping away the reality is, because while we're talking about these issues, we're actually talking about a person, like Jill said earlier.
Yeah.
Yeah. And looking at those complexities, public health insurance funded transportation, the impact that has on someone accessing the healthcare system, it really begs the question of the impact that has, therefore, on the research gap in general, if that person is able to access the whole of the system.
That's right.
Jill, looking at your community, and thinking of this complexity of individuals, can you think of challenges that individuals in Washington might have that may be specific to Washington, or respond to Tammy in a way that nails in on that complexity?
Yeah, well, first I want to say there's no way I understand all the complexity of people's experiences, and because the people who have the most trouble are probably the ones I've never seen. So I think I can just speak more broadly to what happens in the Pacific Northwest, and I've also practiced in the Upper Midwest, and I saw similar things. It's a disparity in resources, and between what we sort of expect normal healthcare interactions to look like and what the healthcare system actually is. And so I'll say Washington State, but we also serve surrounding areas because, for example, if you look at the Hemophilia Treatment Center network, there isn't one in Montana or Wyoming. And so they're picking their closest HTCs, which is Seattle, Denver, Salt Lake City. So then we say that's a high barrier to someone getting regular care. And so on the other hand, like rural America is full of practitioners who can seemingly do everything, but specialty care at this level is really a far reach, even for those like amazing rural providers who can like do everything. So to access, I think equity for healthcare is accessing every level of care, and that for our community, I believe in the HTC system mission, which says like super specialty care is necessary for rare disorders. You can't be the only one or two of someone that clinic ever sees in that provider's history and get like the best possible experience that you're going to have in providing care. So distance is a big thing, but I don't think about it in distance, it's in time. How long does it take you to get somewhere, and what did you have to do to get there? Did you get on an airplane? Well, then time isn't the only barrier. There was a financial cost as well. I hope that technology can help us equalize. So it does require access to the internet or whatever to do telemedicine, but it's not the same as seeing someone in person, but what it is way better than never seeing them. And I think research needs to learn to go to where people are instead of expecting people to come to the research. The more we can decentralize this, the more then we have a chance to access it. And we need to get better about listening and what is your story, and that includes what was your journey before you got to us. Like if I'm as an adult provider, I diagnose pretty severe bleeding disorders in people who have been alive for decades with those same disorders. What was the story that meant you didn't get diagnosed before now? And those are the clues to where the system didn't work and still doesn't work.
You know, there are a couple of things as you were talking that I thought about as examples to highlight some of that. So there's a gentleman, severe hemophilia patient, and if you look at him on the surface, you're like, he's just non-adherent, right? He's just non-compliant. He doesn't show up for clinic. He doesn't seem to do anything. Do we ever stop really to ask why and dig in to try to find out why? At HTCs, right, that's why that care is so important. We typically have great social workers who will help us to try to figure out what's really happening with the person. But it requires so much more than that, right, too, right? To really have an understanding as we talk together to understand the whole person within the walls of the HTC. So in time, you couldn't take off the time from work because you were going to miss that money. So when you understand that that's a barrier for the person, well, what days are you off, right? How can we schedule an appointment for the day that you're off? But if you are labeled as non-adherent, not compliant, now that's a barrier for you and a bias in terms of research, because then we'll look and say, oh, really, you're not an eligible candidate. You know, maybe you don't really fit into this model because we need someone who's going to really follow up. Well, are you helping within the research setting? Are you providing a way for that patient to have an opportunity? Are you leveling that playing field and providing some, financial support if they're going to miss a full day of work? Not that you're paying them to participate in the study, but you're helping them to make sure that they can feed their family or put gas in the car, right? To even get to that appointment for follow-up. So I think those things are important to really focus on. And when you think about the system, right, there's so many things that change because they're a part of the big system. You are required to get your medication from a big systemic pharmacy who doesn't know you, who doesn't know anything about your family, who doesn't know that you're sleeping because from 8 to 2 in the day because you worked all night long. But the HTC knows you and knows to call your grandmother to tell her, hey, send that message to him. We know that he's asleep. So when he wakes up, he can give us a call so we can make sure that he gets his medication. So there are so many things that are different. We have to ask the right questions to get the right answers.
No, definitely.
Yeah.
And there are a lot of neuro organizations actually watching today and taking part in this workshop. We're looking for ways that they can support HTCs and connecting with these community members who may be labeled as non-adherent, who may be facing barriers to care. But I really wanted to zero in specifically on this issue of maybe non-affiliated patients who may not be affiliated with an HTC, or individuals who may be falling through the cracks in terms of reporting data. And that can be, women who may not be showing up in reports because they're getting, treatment in emergency rooms. That may be individuals who are not being included in research. When thinking of the idea of non-adherence, I think of individuals who come from cultures that may have different approaches to health or may have cultural barriers that are in place that may make accessing the healthcare system more challenging. If I think of a personal example, on my plane trip here, there was a situation where a man did not speak English or was non-fluent. And he placed his bags onto a seat behind me, and the stewardess told him he could not place his bags. He thought that she was saying, move to the seat, so he gathered his stuff and put more of his stuff on the seat. And she got angry and started telling him, no, you can't do that. He didn't speak English, he spoke Spanish. And he smiled and said, I don't know. And she said, you can't put your bags there. And it was a situation where she refused to understand that he did not speak English in a way that was proficient to understand what she was trying to communicate. And he did not understand what she was saying and was simply trying to placate the situation. So, serving as an interpreter, I spoke and told him what exactly she was saying. But I can remember the look on her face as she repeatedly tapped her wand and said, "You have to put your bags here," not taking any second to pause or understand that he did not understand what she was saying and getting angrier by the moment. When looking at that situation, even though it's not a healthcare situation, it makes you think of individuals who are accessing the healthcare systems, who may not have English as their first language, who may have cultural barriers, and the sense of dealing with frustration or a system that maybe is not as open to them. Looking at your work, especially with the idea of clinical trial enrollment and how much importance there is in the consenting process, how do you feel the system either serves or fails individuals who maybe have cultural barriers?
You take a stab at that?
I'll start.
Yeah.
So we're not great at it. We're not great at it for complicated reasons. So one reason to me that's very important is, what does it mean to consent to a study? We need to make sure that people who agree to participate in research know what's the research they're participating in. What are we researching? What does it mean for them to participate? What's being asked of them? And a language, for example, can be a barrier. And there's a bunch of other things around what our understanding is of the words we say, even in the same language. So that is a big barrier to participating in research, because it is fundamentally important that they understand what are they consenting to participate in. So we can translate our consents into only so many languages, for example, but we need to be consenting people in a language that they're fluent in order to be sure they understand it. And it becomes a resource issue. Like, I wish I could put that consent in every conceivable language, but I can't. So that is a barrier to research. Then we say, well, what's our workaround? Well, maybe we'll hire translators. Well, then how do we know that the translator understood the research well enough to translate it? So it becomes a vicious cycle of who isn't in research, because we must make sure that consent processes are good. And then the other barrier that we've alluded to several times already is who even gets offered the research. So and I do take issue with the idea of compliance or who's a good, what does that even mean?
That's right.
In healthcare, we say someone's non-compliant when they didn't do what we said. Did what we say to do even make sense for them? So there's, let alone maybe, I think most people want to be as well as possible and live their best possible life, and we should presume that. So first of all, sometimes the things we recommend we later learn weren't the best thing for that person, and we need to acknowledge that we don't have the gold standard right answer for what to do for every medical scenario. We need to tailor the treatment to the person. And the same with research. We need to understand, how can we be the most encompassing, and acknowledge that even though we want everyone to participate in research, that's almost certainly not possible. And we just have to figure out better and better ways to do the research, so that more and more people who haven't been represented can be represented in the future.
I think a way too of thinking about what you just described is just to say, I think with clinical research and the consenting process, we have to explain it to people in a way that they understand. But that's huge, right? Because what you just described with that language barrier, there are so many barriers. If you're not having something presented to you in the way that you can understand it. So one example that I can think of is with a lot of people of color are certainly not monolithic, right? But you have to sometimes be very direct. You can't insinuate or refer to, you have to actually describe in detail what you're talking about and use very direct and concrete words. If you don't, there are some people or people from some communities who may not fully understand what you're explaining, and they can't even tell you, I don't really understand exactly what you're saying. They just sort of get the gist of it. In an ideal world, we would have the ability to say, this patient is from Houma, Louisiana. Do we have somebody here from Houma? who could, understand like this community, understand this person, really relate to them. In an ideal world, we would have that. Do we have someone, who's from Portland? Do we have someone who's from Seattle? How about New Orleans? But without that, I think that we should at least stop to take the time to say, who are we consenting today? And why are we not reaching out to others? Like, why did we not offer this clinical trial to those patients? Let's talk about the reasons why. So the patients that you didn't see, right? Those people that we missed, why are they excluded? Why did we not offer it to them? Why did we not have an opportunity to present this information to them? Again, I think if we start asking the right questions, and if we are asking the right people the questions, then we can try to really start to overcome some of the barriers.
No, definitely. And I guess I wanted to follow up on that. Specifically, you mentioned to start a individual who was categorized as non-adherent.
Right.
I wanted to follow up actually and ask you if with this individual, was there any case where there was an opportunity to recommend a novel treatment for him or her, and how you approach that?
Yeah. So I describe it, especially with hemophilia patients, where whoever you are, wherever you come from, I'll just go, let's talk about what's happening new with hemophilia today. And that conversation may be 90 seconds. It may almost be 90 minutes, and the nurses are knocking on the door, trying to pull me out of there, depending on the patient. I try to meet them sort of where they are. But at the same time, I try to provide an opportunity where you can hear the information. Because believe it or not, sometimes we may have our own bias, right? And think, oh, they're not going to be interested in hearing about this. I can barely talk to them about, product A or product B or this treatment. And when you bring it up, you may get a response that was unexpected. You may have an opportunity to educate, to provide information, and then really provide additional treatment options, also leading into things that are emerging therapies, clinical research, because then the conversation evolves. So I think if you try not to have, insert your own bias and try to make sure that you have the same conversation with everyone, I think that that's a way that you can overcome that. Because you may, again, put yourself in a position where you're asking the right person the right questions and providing the right information.
Thank you all so much for watching that last part. Coming back again together. We have some time to go through question and answer before going into the emergency room setting question. We do have one question from the audience, and feel free to jump on this. But does the chapter have a role on the care team, and how does this work best? We often hear about things going on with families, but aren't always positioned to share back with the traditional care team.
I think everyone has a potential role on the care team. So absolutely. A lot of our success in healthcare is engagement and education and learning how things are working and not working. And I think I'm not the right person to answer specifically, but I'm 100% sure there's a way that would make things better. And the reason I'm not the right person is because I'm not in a chapter. And I'm also not running the clinic. So I need the conversation needs to happen. And I think that's a great conversation to have. And I also hope there would be a role for chapters in research engagement too. So I think, yes, chapters and members, yes.
I think we all have a role in doing this. I mean, it's interesting, when I first got to Atlanta, we talked about how everybody that was part of our team needs to be a part of clinical research, right? And some of the members were a little uncomfortable. They're not used to this. I said, this is a community that has benefited tremendously from research. We're talking about relatively rare disorders. We need everybody involved. We need all groups involved. Because anytime we look at papers, I was reviewing a paper yesterday and looking at it thinking, and then looking at the demographics, and I wanted to say, well, is this a normal population that you see in your clinic? in your area? Or is this a very specific population carved out, and there's still 40% of the patients don't look like this at your center? Because, we can't generalize information if it doesn't reflect the population. And it's tough because there are many barriers to doing clinical research. It's not simple, it's difficult. So I think that's tough. But I think the chapter can help us because, I think obviously we're trying to have this message, and we think it's important for everybody to be involved in research. And it could be as simple as surveys that are handed out, getting your opinions, or it could be a clinical trial, which is very engaged, requires lots of work and stuff. So I think that's where there could be this discussion. I think places like NHF or HFA are good places to have these discussions. And certainly if somebody came to us and said, we would like to help you, we would say, yeah, great. Let's figure out how you can help us. So I think the chapter can help us on everything. I can't think of anything the chapter wouldn't be able to at least help us get the message out that this is, whatever we're talking about is important. So.
Yeah, I was gonna say, like, there's someone in the chat who just said what I just thought, Jill and Robert. He said that a connection, has to be
Yeah.
made. And I think that if you're not sure where to start, or not sure like what role you could play one way or the other, the very best place to start is to make sure that there's a connection to be able to ask those questions. And then don't stop, right? Establish the connection. If there's not anything at that time, follow up to see what could be done.
Addendum to actually what turns out to what they both said is like, these all require local solutions.
Yeah.
So there can be national themes, but every HTC is different. Every chapter member organization is different. And I know anyway, that not everyone who's coming to find their community is necessarily plugged into an HTC. And not everyone in an HTC who's seen an HTC is necessarily plugged in with their member or chapter organization. And it should be whatever happens, wherever it is, with whatever resources they've got, which may be almost nothing to something kind of great. It's got to be a partnership, because there's no one person who knows the true truth in that system. And what I hope anything would happen would be a conversation where it's not the HTC telling the chapter what the message needs to be. What it needs to be is a coming together to identify, or what are the mutual needs, so that people can start working together.
Does it seem like there is a need for like a standard you said, I know every chapter and every HEC is different, both in capacity, but maybe a need for a standard form of communication, or some, way that we can help equip either HTCs or chapter organizations to make those connections. I know the national solution is events like these, it's forums, it's opportunities for HTCs to connect with member organizations and the community. And, we need more events like that. But also, having a method to encourage or equip community members and community organizations to communicate with HTCs.
Having some kind of structure, the scaffold, to make sure that things get started. And then there needs to be flexibility and iteration, so that when things are working, you can keep going. And when something's not working, it can change easily. And then some system, and I'm thinking, this is like pie in the sky stuff for me, but hopefully there's some way to do this that says what was working for some places, so there can be shared growth instead of just things being learned but not being shared across the system. So I think that's where the chapters, members, and community organizations, you guys know best how you guys communicate best and where your gaps are. And it's up to us to make sure our providers of all kinds and HTCs also come forward to acknowledge that we have our gaps and our strengths and figure out how to do things well.
Oh, definitely. And that sharing of, looking at the chat, hearing you, that sharing of what's working, I think is really, necessary. In the next 2 days of this, we're going to be, collaborating more, but it seems like one of the most important parts is, if something's working for you, how can you share it with, Atlanta? How can you share it with, Tammy? How can we get these best practices out there, because
Yeah.
it seems like everyone is working from that perspective of what can I do? But when they hear someone else doing something else, they say, wow, that's really amazing. Why did I not think of that earlier? And I guess this leads into the question of, Jeremy asked what role Athens has as a central database could play in tightening those connections.
Yeah, I saw that and I was, sort of thinking, I think that there's some things that perhaps we could make sure are available and explore in terms of maybe even looking at what some of the outcomes are when some of those connections are established, maybe tracking some of those connections. As Jill mentioned, there's going to be like some variation because connections are really established, not necessarily using a national standard, but using what works locally, right? So every HTC is different. Every chapter is different. Sometimes they're large centers, small centers, large chapters, small chapters. But there still may be a way to ask more specifically about some of those connections that are being made, and maybe having an opportunity to follow up to see what the outcomes are.
Yeah, I think the best practices are a good start nationally. And like Dr. Johnson was mentioning before, that the solutions ultimately will be local, and so you could take those best practices, adapt them, like Dr. Singleton was saying, and then come up with a solution that works. And it might just be what works nationally anyway. So I think that's that's a good way of approaching this.
I think honestly, as we go through this workshop, I think we should all be thinking, what's working for us? What have we seen that's worked? What is working for us? So then when we come together on day 3, we can come together and say, this worked for me. I saw that this worked for me. This was really great when this chapter organization did this. Or from chapter organization perspective, I have been trying to do this, but there are legal hurdles in my state to accomplishing this, and find those solutions, seeing what worked and what didn't work, or what we want to do. Because there are things we want to do that we legally can't, or that there are legal hurdles to accomplishing. And addressing that and seeing what other solutions we can possibly have, I think is really important. Going back to that, introductory keynote, the top 10 list, but maybe in addition to that, a list of what is working for us or what we really want to try. I mean, this is honestly an amazing lead in to the next panel with you, Dr. Stonio, where you talk about some of the things you've been doing and some of the unique things you're doing to address emergency room care and actually address, barriers to care in them. If there's no other questions, I'd love to go into that right now. All right, going once, going twice, and we're going to go into it.
Looking at emergency rooms and emergency facilities, lab work, HTC, it really becomes a question of healthcare systems and healthcare systems addressing patients' needs, especially where they are. This becomes a problem when individuals don't have access to equal qualities of healthcare systems, or when healthcare systems don't treat them with the same degree of care. Looking at this from a programmatic solution base, are there any hard truths that we have to address or maybe reconcile with when addressing, disparities in access to care, when the issue can be quality of care or quality of facilities available? It's a difficult question, but is there in some way a need to acknowledge the reality?
Yeah, we definitely need to acknowledge the reality, because if we're not working in the real world, we're not going to find the right problems and we're not going to find the right solutions. Mm-hmm. One of the real challenges is the economics of healthcare. It's a burden economically for a person to have a diagnosis of any kind. And insurance company support for different diagnoses widely varies. How much it costs to get care widely varies. People don't know what to expect. And I think it's really unfair that a person who has a diagnosis where there's an automatic trigger to have to justify the same treatment over and over is at risk to not get that treatment some of the time. Mm-hmm. Or if there's an arbitrary amount of dollars that you can spend on your health care, well, the person living with a bleeding disorder doesn't get to choose what their diagnosis is or what's the appropriate treatment. So it feels inherently unfair. I think some of the solutions are that we need to develop the evidence so that we can write better guidance to say, here's what is the standard of care you would expect. Here's the range of what people should be getting so that it's clear where the gap is. It's clear that we're not doing what we're supposed to do. So that's something we could do better.
No, thank you so much. That's such a cognizant point. Especially just acknowledging the reality of the situation and where we need to place our solutions, especially as we discuss more programmatic solutions, throughout the next 2 days. Thank you so much, Jill.
Thank you.
Thank you so much for those incredible points we made. Looking at the solutions end of everything, we've talked about policy priorities. We talked about making those 10 lists of things that you want to see changed. I would really love to know from your perspective how we can affect change in the clinical treatment and clinical trial diversity issue space. How can HTCs work with or through member organizations to reach patients that may be unaffiliated, may not be connected with HTCs, patients who have difficulty connecting with health services, patients who may find barriers, or even patients who are classified as not adherent. I'd love to kick that over to you, Jill.
Sure. Well, one of the hard things is you don't know what you don't know. So we have to be really open to when we see a clue about what we don't know. And that involves a listening. One way that, at least in our experience, that's been pretty effective is when you find one person, it's never just one person. It's a family. And it's a family that's connected to a community that may not be the community we've interacted with. So every time we have a new diagnosis, a new transfer, it's a chance to realize not only is the person in front of me need care, but they're probably the key to a whole other group of people that need care. And those people not even live near us, but that's the value of the HTC network is it's throughout the United States. So we can help say yeah, it sounds like your sister also needs to see someone and they don't live here. Here's the CDC HTC website, or I'm happy to call that HTC and say, hey, there's a sister I know about that really sounds like they need to see an HTC. And I think you do it one person at a time.
Yeah, I don't know. The first thing that comes to mind is maybe to connect with the social workers at our HTC and just say, hey, this is something that I think that we'd like to do, because the advocacy organizations, HFA, in the community, very powerful, very visible, very active. So there's always something going on in terms of connecting with the community. I think the issue is, as you pointed out, the people who aren't there, right? So I think between the HTC and the knowledge that our social workers have of kind of who's out there, and the knowledge that the advocacy organizations have, with who's attending the events, we could try to focus on patients just in terms of awareness, reminding them, hey, these organizations are available, and then really trying to figure out how could we be consistent with maybe having a presence when there are maybe educational sessions that are available, to say, hey, you're having this educational session to discuss this therapeutic option, but we want to just take 5 minutes to have clinical trial awareness for everyone who's here. And I don't know, maybe sometimes we can think outside of the box about creative things that we could do too, to really reach people who aren't present with some of the activities with the advocacy organizations, but at the same time, even people who attend a lot of things still can benefit from having that knowledge, I think.
And I think, I think discussed here, I think just raises so many more questions, which I hope, we can answer in the next Q&A session that will be following the panel.
But it's a good place to be when you end with questions. Don't you think? Yeah, that's a good place to be. That's a good place.
No, I think I'm really excited about, getting a chance to have you respond to everyone's questions, and especially, for just continuing this work in the day too. So thank you so much.
We'll actually keep this Q&A very brief in order to get to the next panel. But that idea of solutions, we discussed, previously. But what's the best mindset that we can go into, like the next 2 days in order to actually reach those solutions? And the answer can be as simple as you want it to be. But I guess what's a good mindset if you're an HEC staff coming into this?
I think it's I think we should consider everything. Hopefully we're in a good space where we can discuss things and people aren't afraid to bring up solutions that may seem a little bit out there. It's okay. I mean, this is a brainstorming session, so it's okay as long as you come up with the answer at the end. Brainstorming sessions, you might have a bunch of ideas that in the end probably weren't going to work, but that's okay.
No, I definitely think another thing, component of this, for the chapter organizations that are attending, and that attend all 3 days, there will be a grant awarded, ranging up to $2,500, and it's not a super huge amount, but it can help maybe on the chapter organization side put some of these ideas into action and get them rolling. And we talked about the need for communication, but with these brainstorming sessions, with these like time opportunity to talk, we could actually get some momentum on the solution. So I think that's going to be really great. I can definitely bring it into our next panel.
So looking at the issue of communication between HCCs, we have to wonder how much can be improved by improving intake, patient intake and facilitation. There's been a lot of work done in the cancer community around specifically patient intake, but in some ways it feels like some of the solutions have been coded in specific diseases. How can we make sure that when solutions come up, they are not just bleeding disorder solutions or cancer solutions, but healthcare system solutions?
That's a really interesting question, and I'm going to have to think about it. I can say that the solutions in HTCs are almost certainly going to be different because HTCs are different. It's a really different system for comprehensive care than we have the privilege of having throughout the rest of healthcare. I like being in the system because it feels like it's the kind of doctor you want it to be, because you get to take care of a whole person and their family in one setting. And there are places like that in the rest of healthcare, but a lot of it really is set up to take care of one thing at a time. And in HTC, the idea is to take care of the person at a time. So I would love to see us develop the evidence that says, here's what happens when you do this model, and why would you want to generalize that to other care? But it is really different. And each HTC is set up very differently. And so I think someone needs to survey, what's working in HTCs and what have we tried that isn't working, so that we can share that knowledge in the system.
Mm-hmm. And looking at intercommunication between HTCs and emergency room settings and facilities. Mm-hmm. The question of not every HTC is built the same way, and not mm-hmm. every emergency room is built the same way. Mm-hmm. And setting that precedent with HCC systems. Have you heard of anyone or any programs out there that are trying to bridge that gap, maybe develop emergency room interventions?
Yeah, I'm not going to know the answer to that question, but I can say that the HCCs have done surveys of themselves and have published papers on why the system results in better outcomes for patients and is a more economical way to do healthcare. It is sitting in a network, though, of healthcare needs. So it's not, it's the ER, it's the hospital, it's working with the primary care physician, because although we sometimes stand in for primary care, we're actually not primary care. We're not there to manage the blood pressure or the blood sugars, all these other things that someone really needs in their healthcare system. And the other thing that I think is important is the interface with the lab. Mm-hmm. Because the labs are the key to the right diagnosis, to monitoring of the treatments, and those labs need to be excellent, and there's not equal access to labs either. And that's critical to have the right diagnosis, and it's critical to be able to monitor your treatments, whatever they are, whether it's a specific factor or maybe you have another general treatment. And it's also the key to research.
Yeah, following up on that, and specifically for unequal access to labs. Looking at communities that are rural or maybe have less access to the same quality of labs, Are there any efforts that are being made to maybe have a quality in labs, or maybe decentralizing labs?
Yeah, it's a really good question. It depends on which test we're talking about. Some of these really specialty coag labs are hard to decentralize. They require very special reagents and care. At the same time, when a sample has to travel a long way, then it's kind of at risk for something to happen to it. And that's different than, for example, genetic testing, where DNA actually turns out to be pretty stable.
Yeah.
So we could make centralized genetic labs. But it is, I know it's an initiative that many recognize, including WFH globally, to say that improving access to testing and hopefully through technology development will enable people to be able to access diagnosis and monitoring better.
Hi, thank you so much for coming back. That was a terrific live session we just had. For this next session, we'll be talking about emergency room care and healthcare systems. It's our goal with this next session that we talk about the intersection between emergency rooms, HCCs, and general healthcare system facilities and communication. I'm joined today by the wonderful Dr. Robert Sidonio. I'd love for you to introduce yourself.
Yeah, my name is Robert Sidonio Jr. I'm a physician and pediatric hematologist. I'm at the Hemophilia of Georgia Center for Bleeding and Clotting Disorders at Children's Healthcare of Atlanta. It's a big title, so long title. And I've been there since 2014 and work with lots of lovely physicians and staff at our center.
Thank you so much for joining us today.
Sure.
For many bleeding disorder community members, emergency rooms are the primary entry point for treatment, especially for uninsured individuals or rural people who may have to use emergency rooms as a routine center for non-emergency but urgent care. And in that, we see an issue, especially related to access to healthcare systems as a whole. If we're thinking of healthcare systems as a holistic care system that is designed to generate the best health outcomes. Some individuals in the bleeding disorder community are not getting the same level of outcomes due to not having the same either scale of facilities or total access of the healthcare system. You've done really a lot of amazing work studying underserved community members. I know I've heard you've done a lot. I've heard from my colleagues and seen that you've done great work also in communicating with emergency rooms. I'd love to begin this session before we go into the panels by just talking about the issue of emergency room care and the complexities that it causes for certain members of the community and how it can negatively impact health outcomes, but also the research gap.
It's a tough thing to deal with. So, I grew up in a small town in South Alabama, and so we didn't have access to any major medical centers. We would have to drive hours to do that. So I'm quite sensitive to the fact that we didn't always feel like we had access to as high quality care as somebody that lived in a larger city. And so I always sort of think about that perspective when we're talking to our patients. And in our center, in our state, there are only a few hemophilia treatment centers, and there's extremely large distances between them. So many hours people have to travel, particularly in the southern part of the state. It's extremely underserved. I know there are a lot of patients down there that haven't been identified, or maybe have been identified and haven't actually got to our center. So, there have been a number of things that I've done over time that are related to bleeding disorders and unrelated. One of the first sort of forays that I got into this was our work in evaluating for children for possible child abuse. And so one of the things that I noticed when I was doing this, and the reason that we were involved, is because oftentimes you need to evaluate for a possible bleeding disorder. And you hear a lot of families say, oh man, everybody was accusing me of beating my child because they had bruises and bleeding. And they were always calling Child Protective Services because my kid would show up at the clinic or show up at school with covered in bruises. And so what I noticed is that when they did a workup for a bleeding disorder, it often was on certain populations, right? They weren't working it up in a wealthy upper middle class, you know, paid up family from northern part of the city, right, from the richer suburbs. And so that really bothered me. And so some of the work that we did when I was at Vanderbilt was that we were going to order this lab on all the patients. So we sort of said, we're going to remove the things that people are doing. We don't want people to go into a room and judge and decide that family seems like they're okay, or that family doesn't seem that way, because they're bringing their biases in there, right? They're bringing their own personal opinions and their perspectives. So that was sort of the first interaction, is that we standardized the workup. We worked with the child abuse team. And that's actually helped identify patients with bleeding disorders as well, because they do the workup early, and you can, within 4 to 8 hours, you'll know if somebody has a definite bleeding disorder or not. And so that limits the amount of trauma that the patient has to go through, the family has to go through. They're not meeting with a bunch of child protective services. So that was one way that we sort of addressed that. The other way that we sort of did was we had this initiative in which we were trying to do better at managing acute heavy menstrual bleeding. So girls that have such terrible bleeding, they have to go to the emergency room. And so they would go to the emergency room, and we wanted a standardization to the approach. And I feel like that's probably the best way to remove sort of the human part of this, is that if somebody comes in with this issue, there's a standard approach to it. It's not, I feel like this patient is full of it, or I feel like this patient's being, is being over the top about this and I don't believe them. You just do the same approach, right? Mm-hmm. So that limits some of their personal biases, their opinions, and maybe the patients come in and they're feeling terrible about it and they're very difficult to interact with. And so again, it removes that sort of barrier. And so everybody got a workup for von Willebrand's. It didn't matter what the issue was. If you met this certain clinical criteria, you got worked up for it. And what we found is that the emergency room really appreciates the standard approach. It's guided by us. We tell them, this is what we think you should do to manage it. We want to make sure that you send them home with these medications so they don't return. Most of these patients probably don't have a primary doctor, so we need to make sure that they have a follow-up appointment. So all these were ways of sort of trying to limit some of those problems. And then for our bleeding disorder patients that are identified, we set up this plan where everybody has a standard note in the chart. So everybody's note looks very similar, but obviously with different details. And that way, when somebody looks in the note, they see a very clear-cut management strategy, right? And so we don't have a bunch of different templates. We have one single template, and it's usually a fairly clear-cut plan. So we want families to have a personalized bleeding plan. And we also encourage them to call us, because we want them to know, call us ahead of time, because if they call us, we can actually talk to the emergency room first. And so when they show up, they know, oh, this patient might have a bad muscle bleed. You really should look for these things and strongly consider doing imaging if you have any concerns. That way more action is rapid. Their families feel like, oh, they're addressing the issue that we know is the problem. Or we might say, I'm not sure what's going on. The kids, something weird's going on, so you really need to look for a lot of things. And so it helps them, and then they know who's calling, and they just call us back immediately. So they feel comfortable with us. And so, I mean, it's tough. Emergency rooms have so many people rotating through it. You can't educate every single person. And so you just have to empower the patient, empower the people in the emergency room so they feel comfortable, like, oh, here's a nice order set. It's gonna guide me on what to do, so.
Yeah, it seems like you focus more on creating a template or a system to address ever-changing personnel.
Yes, and it has to be that way. And we try to create something where it eliminates some of the decision-making where it might be based on their personal beliefs or opinions, right? Mm-hmm. So if somebody comes in with this, they're like, well, I don't know, they seem okay. It's like, well, no, they came in with bruising, we don't know what's happening, and so you need to send these labs to investigate for it. Mm-hmm. So, or like, oh, that family is, they seemed a little sketchy, the dad was a little odd. Yes, that might be true. We have people are strange, and sometimes people are quirky, and it doesn't mean that it's always something bad. Mm-hmm. But then they still order these labs, mm-hmm. and it helps guide them and say, oh, this patient actually has mild hemophilia. That's what's going on. And so it hopefully eliminates some of the potential things that could be happening. And you really don't want people's origin story to be people thought I was beating my child, you know, that kind of stuff. So
No, definitely. That's really important, addressing medical trauma in that way, and the potential repercussions that it can have, especially in minutes into the the healthcare system, which
Sure.
being diagnosed with a bleeding disorder is.
yes, I mean, oftentimes the diagnosis is made in an emergency room. Sometimes it's made in the clinic, but they've had interactions in the emergency room and they think, oh man, everybody thinks something's bad, I'm beating my child or something. And so you hate for them to go through that. Obviously, I think they also need to understand on the flip side that child maltreatment and child abuse is unfortunately extremely common. And so they have to address this because we don't want people going back home in bad homes. And so I think if patients understand the other side of the story, why people are being suspicious, because you just have to. And they may have seen two cases immediately before that. And so they have to remember this. But so that's what we just have to really provide the structure to help limit some of these problems from happening. We can't eliminate them, but we can certainly limit them.
I guess, when moving, kind of like taking, that and pivoting into a focus on research.
Yeah.
You've done a lot of research specifically on underserved communities, and in this, using the HCC database, and do you often use insurance claims?
Well, yeah, I mean, so when we're doing research, it depends what we're doing, right? And it helps that we're in a pretty diverse, the makeup of our clinic reflects what we have in the community. And I think it's also important that our staff reflects a lot of what we see in our community as well. And so when we're doing research, we're quite aware of this. I've been on a number of organizations and committees, and one of the things we notice is that research participation is lower in certain groups, right? And there are historically lots of reasons for that, right? And so we want to make sure that those opportunities to be on life-changing trials are offered to everybody. And we want to make sure families feel comfortable with us, right? And so we have to create a staff, an environment where they feel comfortable, they don't feel like they're not part of this, or they feel like this is a group of people that doesn't get me, right? They just culturally will never understand this. And so I think that's really, really important. We recently, one of the things that was really nice is that we got a sense from our Hispanic patients that they felt like we weren't as communicating as well with them. And one of the things that we looked at, and this was all done by our nurses, is that they said, well, we're gonna, one of our nurses, we're gonna need a nurse that actually speaks Spanish fluently, can do medical interpretation, and that helps a lot. We don't want her to, one thing is we don't want her to say, oh, you're only gonna see Hispanic patients, right? We don't want that, obviously. But I think that's really helped the patients feel a little bit more comfortable. We also brought an interpreter, a single person, into our clinic, and they just sit in our clinic and interpret for us. So we had the funding for this. It's nice if you have this. And the patients seem to appreciate having that person, because oftentimes the one that you do over online through an iPad is just not very good. And the patients tell us, they're like, I don't know what that was. That didn't make any sense. Like, that person didn't make any sense. Like, that person did not speak Spanish very well, or whatever language it is. And so I think that's really, really helps. When it comes to research stuff, most of our research is done in the clinic. It's typically in that setting. There are a few times where interactions in the emergency room are important for this. There certainly are surgery studies where we have. But what was really important is that when we've looked at patients that are enrolled in clinical trials, it actually reflects what our community is. We have a number of African American, Hispanic patients that are enrolled in trials. But one of the challenges that we have to overcome is that if it's a well-funded study, the consent forms are all going to be translated to multiple languages. That's quite expensive. But if it's if I have this really small study and limited funding, it's not interesting it's not going to be interesting to any drug company, so they're not going to pay for it, and it's not high enough level for to get funding for. But it's an important thing that we feel we need to do. It's very difficult because you're paying for the translation, and certainly we always translate into Spanish. But it's very difficult to translate into so many different languages. It's just so cost prohibitive. But I always feel like we're really limiting because we can only do English or Spanish speaking. That limits our population. So it is tough. We try to do our best to make sure that when we do the research studies, we're looking at the demographics, because it is important. We have trials that we do, and drug companies notice this too, and they get called out on it. We've had some trials where they say, majority of the patients were Caucasian. Mm-hmm. That's not my clinic. Yeah. And the drug companies actually reflect that. One of the companies is actually saying, oh, we understand this. We had to do this in Europe. Most of the people in Europe are Caucasian. But we get this, so we're going to actually do another real-world trial in the United States so it better reflects your population, so you feel comfortable using their products, which they would not have done that 10 years ago. They would have just said, yeah, whatever, we don't care. But I think they're seeing that and understanding that, and enough physicians and community members are saying that. They say, okay, this is important to them, so we're going to do it. So
there's even new government guidance on post-market studies to amplify research where there wasn't enough diversity in pre-market study pools.
Yeah, no, I think that's important, because I think you get patients that are involved in trials. They talk about their experience. They say, this drug changed my life, or this survey was really, really important. And so you really want people to get that. I mean, oftentimes discussions on social media, discussions amongst our patients, that's the best way to recruit for things. So
no, definitely. And formal post-market study.
Yes, exactly. Yeah, exactly.
And this question is based kind of on actually a research paper you wrote. But in it you said that data on women is harder to find due to women more primarily using emergency room services as their treatment for their bleeding disorders.
Yeah.
If you could go into why that is the case. I know there's a difference in the insurance claims data that's received from HTCs compared to
Yeah, I mean, the biggest part, particularly in women with hemophilia, that's where the struggle has been. Women with von Willebrand's, we have a lot of things that are getting identified, but oftentimes it's the coding. So the United States, it's a unique situation, right? Every time we talk about this and guidelines, people in other countries like, what are you talking about? I said, yeah, sorry, this is a US-centric problem. Like having labels, having the diagnostic codes, because that's how we get reimbursed. Other countries are like, whatever, we put down the diagnosis, everybody gets paid. So that's where the struggle is. And so for a very long time, women with hemophilia would often just have the label as hemophilia carrier. Although that's accurate, that doesn't come with the medical services that you would expect, that you would anticipate if they had mild or moderate hemophilia. So most of the hemophilia carriers are going to actually have normal levels, but the next most common one is going to be mild deficient. So they're going to have levels of 6 to 50%. Most of the carriers are in that 20 to 40%. And so the problem is that if I just do insurance claim data, it's super hard to find them, right? And so that's a problem for a lot of reasons. So the one problem is that when people decide to do trials, they need to survey and say, how many patients are out there? Is this study feasible? Are we going to be able to do that? Where are the patients? There's a lot of these patients here. There's a lot of patients in North. And so if you can't find them, quote unquote, find them, then companies are like, we can't do this trial. We did survey data. We've gone out there. We just can't see them. So I can't justify saying we're going to spend $1 million on a trial. So that's one problem. And so, so it's really, really important that those patients do this. And so what we tried to do is that we came up with a nomenclature, a system of how you should diagnose and name patients. Pretty simple, straightforward thing. You'd think this is no big deal, but it is a big deal because it's important to get that. So now we're getting documented. We see the patients. They're going to show up in medical claims in the next 10 years. And that's going to show. So then I'm going to be able to do studies in 10 years from now. I'll be able to say, hey, I want to look at what's going on with women with hemophilia carriers. And when I do like insurance or medical claim data, I'm going to see that, right? So I'm going to find those patients. They're going to be adjudicated, and then I'm going to be able to publish that, and all my colleagues will be able to. Yeah. And so then you disseminate that research. Companies see it, patient groups see it, other funding organizations see it, and now all of a sudden there's an interest in doing research in it. Yeah. And so that's where the problem is. And so It's getting better. We notice that you can find some patients more and more, but we got to get the patients into the hemophilia treatment centers. Most of these drugs are extremely expensive, so insurance companies are going to notice it. It's going to be seen on medical claims, right? If you get a factor product and somebody's getting it, people are going to notice that, right? These aren't things that are inexpensive. And so I think that's really important to get done. So we have these organizations where we do this sort of, we call it's considered tedious work, but it's incredibly impactful because we're doing this stuff and people are like, you're spending all this time writing a paper about how to name people. Like, it seems silly, but it's important, and it's going to make everybody, when they write papers, they're going to use that naming system. So now when I do a PubMed search, I'm going to find those papers. It's very difficult to find those because they're often buried in papers, and you can't really do this. And so I think you're going to see some of this get better. And what's really great is I get notifications. I set up my email to get notifications anytime there's a new paper on hemophilia carriers, women with hemophilia. And what's great is in the last 5 years, there are so many people working in this field that were not working in it before. There are very few people working in it. And when I first started working in it, I did not get encouragement to work in it. People would often say, man, there's just not that many out there. This is, you need to spend your time working on stuff that's, you're going to be able to get something done in. And to be honest, that actually made me more annoyed and mad, and probably actually made me work harder in it. Because somebody tells me what we're doing is dumb, and it really kind of pissed me off. And I was like, yeah, we're going to show them that that's not true. And so that's really what's sort of driven this, and it's awesome to see so many people working in this field. I mean, I hear people come up to me and say, hey, I'm working in women with bleeding disorders. And I was like, that's great. Like, that's your field. Like, that's an area we need more young people in. So that's what's been awesome to see.
And actually going further into that, with this work that you've done to standardize naming and for coding purposes, is there a push to make that a widespread practice, or is the way you did it,
Yeah, I mean, we put the nomenclature out there. There's an organization called ISTH, and their job is sort of, we always joke, it's sort of like C-SPAN for hematologists. But we do all this sort of work, like what should we call this? How should we name this? How should we like design, what is a major bleeding event? Like, let's define it. What's major surgery? And the reason all these sort of elements, they call them common data elements, or they call them, different things for research, is that we're trying to come up with a standard system. So when this person, a young person in a faraway center is saying, I want to do research in this, they look it up and say, okay, I'm going to call the patients this is how I'm going to name it. And then I'm going to use these data elements, this is how I'm going to gather data on them. And so it standardizes everything. That way we can actually like compare data across platforms. And so that's important. And some of the stuff that we did in von Willebrand's for medical claims, what it was trying to show is that what we're doing is probably making it better. It's not perfect, because there's been data a long time ago that takes 10, 15 years to diagnose a patient. And what we saw in some medical claims is that it's actually getting closer to like a couple of years. Although that's not great, it's still better, it's progress. And so, we have to take what we can get. And I'm still convinced that it's gotten even better since then. But that's where you can use medical claims to show this. And it also helped us show that we're probably not doing very good in heavy menstrual bleeding. We really need to focus on that. So.
And to add some context for viewers, this discussion is focused on medical claims data and ICD-10 codes. And feel free to correct me if I'm wrong, but with coding, when you have a specific health issue and you receive treatment through the healthcare system, you are coded with a ICD-10 code that refers to what condition you have and what the prescribed treatments are for said condition. And the issue arises in emergency rooms where there are non-specific codes that don't refer to the specific treatment that patients are receiving. And for certain populations that primarily receive care through said emergency rooms, they are then being unspecified data, which is not as usable or included in future research. And that's been a problem for a long time.
Yeah, one of the big problems was in the older coding system, the ICD-9 coding, there was a specific code for von Willebrand's. And the problem is that you can have a patient with the mildest von Willebrand's, right? and then you have another patient that has severe von Willebrand's on prophylaxis, getting lots and lots of therapy. And even though they might have what looks like a different code, it all ends up funneling into the same code.
Yeah.
And so it's hard for me to analyze, like, I want to do research on this population. These patients are still in there and I can't tell what they have. And so the new coding system is supposed to do a better job of separating them out. And what's really interesting is that a couple of companies we've worked with have actually tried to come up with, like, the big thing is now machine learning. Can we like figure out how to use some sort of artificial intelligence? Is there an algorithm where they can look at characteristics of this patient and say, okay, even though these two patients have the same code, we know this patient has severe hemophilia, we know this patient has mild hemophilia based on sort of the fingerprint analysis from machines. And so this machine learning is really going to help us to do a better job of claims data sets. So.
Well, I guess the issue and the reason why I brought this up, is if we have a healthcare system access point, which in this case is emergency rooms, and we know that it serves as the principal entry for care for certain communities, especially underserved ones such as rural, women with bleeding disorders, uninsured individuals. And we know that it is in some ways, or has been, unspecified data that creates problems for research and has created problems for research, especially when you combine it with reliance on HCC data sets for research as well. So looking at that issue of addressing access to care in emergency rooms, would you say that addressing access to care in emergency rooms and improving those systems is vital to improving representation of underserved communities in data sets?
Yeah, I mean, it's important because you want to make sure they have a good experience. And, although the emergency room shouldn't be used as the way to diagnose and identify patients, it often is used that way, right? I mean, that's the way it is in the United States healthcare system. But what you want to do is help identify those patients. And and it's hard because emergency rooms are not set up to do a lot of these labs. So for example, when we tried to set up emergency room to diagnose teenage girls with von Willebrand's that have heavy menstrual bleeding, it was a major challenge because those labs don't come back that night, right? And so that person that comes off service, they actually assign physicians the next few days that labs that were ordered, that they follow up on those labs, right? And so that's challenging. They don't have the staffing for that. They can't wait for a lab it's going to take a week to come back, right? And so that's a big challenge. And so we had it set up that way. We had them where they followed up. We got our emergency room to understand that it was really important. We tried to bring a lot of our labs in-house so we can get the lab turnaround faster, because we didn't know that was an issue why the emergency room doesn't want to order complex coagulation studies, because one, they don't know how to interpret them, right? You're getting people to order stuff they don't know how to interpret. And so that's potentially dangerous. They could just overlook something, right? And so this is where it's a challenge. We're trying really hard, but it's a struggle to get these patients following up in our emergency, in our clinics to finish the workup. Because we often tell families they might start the workup inpatient or might start it, if in the emergency room, but we're gonna have to finish it in the clinic, and we need somebody to interpret those labs, right? Because they're complex, and so that's where it's really important. And so we try to do a better job of that. We get our trainees, anytime they get called about it, they write quick phone note that actually gets sent out to everybody in our working in our group. And our nurses, it's awesome. They go through that and they look at all these patients and they're like, hey, this patient had a circumcision bleed. He got worked up for it. We need to follow up on that one to see if is he going to be one of our patients. Or this is a patient with mild von Willebrand's. They were seen 7 years ago and they just got lost to follow up. And so that helps make sure that these patients get back into our clinics as best possible. So, because it is a struggle, and we understand that they may just not have the means to come see us in clinic, and we have people to help with that kind of stuff. So
no, definitely. It seems like a lot of your work is that combination of addressing underserved community members, and specifically addressing lack of communication and barriers to communication between facilities and the healthcare system.
Yeah, I mean it's you see these problems, And what you don't want to do is you don't want to go the route and say, yeah, that's the way it is, sucks, you know, nothing we can do about it. So we really try to say, okay, there's little things that we can do that can make a huge difference. We have to try to do it where we don't isolate somebody and, you know, we don't get in a room and just say, man, those emergency room docs suck. They don't know what they're doing. They're terrible. That's fine to vent at meetings and do this, but you have to be able to work with these people, and it's important that you get them to understand why this is so important. Like when we did the heavy menstrual bleeding protocols initially in an emergency room, none of the emergency room docs thought it was an important issue. They just think, why is this a big deal? It's not that common. We're dealing with asthma attacks. We're dealing with RSV infections. We're dealing with, you know, meningitis. And I said, okay, you try. So we had tried to explain to them. It took a long time for them to really understand it. Once we put the protocols in place, they're like, okay, we get why this was important. It's actually helped us to be more efficient. And so that's really the way you have to approach it. Just sort of saying, you know, these places suck, these people are terrible. Like that's not gonna, you can say that by, you know, you can say those in private conversations, but then you gotta say, okay, we gotta empower these people. We gotta make sure they do the right thing, even if they don't wanna do the right thing. We gotta make sure they do the right thing.
No, definitely. Thank you so much. You know, I'm really looking forward to the panel that we have, and you know, hearing Tammy and Jill and your thoughts. You know, further and how we can, you know, bring in member organizations, how we can empower individuals and work with emergency rooms and HCCs. Thank you so much.
Yeah, thanks a lot.
For many bleeding disorder community members, emergency rooms are the primary entry point for treatment. While for a patient's long-term care and treatment plan may be managed by their HCC, emergency rooms serve as the primary entry point for rapid and potentially life-saving treatment. I'd love, you know, really to talk about your work with emergency rooms specifically, and the work you've done to increase the communication between facilities and to address, you know, that crux of the issue.
Yeah, I mean, that's a tough one. And when you go to any medical meetings, you often hear that concern. I really wish the emergency room knew more about my condition. The problem with that is that the emergency room has to deal with so many different things. And so I think instead of making them understand everything about bleeding disorders, I think they need to at least understand that there's someone they can call and contact. And so, you know, we've done a number of initiatives with the emergency room. Most of it was focused on how to do better for acute heavy menstrual bleeding management. And so we've had a couple initiatives with that. And actually when we give them a lot of guidance, structured things to do, we help them order the right drugs, tell them exact doses. They actually appreciate it a lot because it helps them because they don't have to look it up or call somebody. We also try to be as polite and nice to the emergency room as possible. Sometimes it's hard to do that when you get frustrated with some of the people in the emergency rooms. But you want them to be able to call you at any time, to feel comfortable to call you. All of our patients have a specific personalized bleeding plan down to the patient with the mildest of conditions. We usually say for milder bleeding conditions, you should do this, or for severe ones, consider this. These are the medicines they have. So I think that helps. We put the phone number on there, they know to call. We also ask our patients to call us before they go to the emergency room, because then one of our trainees or one of the people on call could actually call down to the emergency room, say, hey, this is this patient. This is what we think is happening. This is what we would likely probably need to do. You might have to order an ultrasound. You might have to order this. So at least when they come in, there's an expectation of what needs to be done. Hopefully it limits the long explanations of what they have, which I'm sure the patients really don't like. So I think those are the kind of things, they're little things, but I think it helps. It tries to improve the experiences of the patients. But you know, it's always going to be difficult if they're in remote emergency rooms. It's always going to be a challenge. But at least if you empower the patients, they understand what they need to do. They understand clearly what their plans are. At least helps, and they know that they say, hey, you should just be calling the fellow or the trainee overnight, and they always know they can call us for any, you know, concerns. So
yeah. And Jill, do you feel like, you know, basing off what you know, like Robert just said, do you feel that like there's a sense of advocating for, you know, community members or patients, advocating for your patients in that?
I think that's one of our most important jobs, is advocating advocating for our patients. And part of it is educating them on what they've got and what their plans should be. And the other part is educating our counterparts in the healthcare system on, this is an important thing to pay attention to, and here's what we need you to do. And the clarity that Robert just said is really important, because they want to help. They're in this, they want to help the patients, but they haven't seen that before. They've only seen it a couple times in their life. They don't have time to go learn what we've learned about for 20 years. They need help to make a treatment plan that makes sense and move on to the next patient. And that's one of the challenges, is the emergency department or an urgent care setting isn't meant for continuity of care. It's not meant for long-term care. It's meant to take care of a short-term acute need that's happening right now. And then it needs to go to someone else who can take care of it longer term, which is us. So it's not meant to be, it's teaching the ER who your patient is and what their long-term treatment plan is unrealistic. That's not what they're set up for. They're set up to manage that thing that can't be managed anywhere else right now, and to get them to the appropriate care setting after.
And I guess, oh, sorry.
Yeah, no, I mean, I think one of the things that when we have patients, for example, a younger patient that has a central line, that can be a lot of concern, because you want to make sure that they have the right supplies. And, they can't always use our emergency room. Like, they may live far away. We're in the northern part of the state, and patients that drive hours. And so we always say that, before something happens, make sure you find an emergency room that you feel comfortable going to. You call them and say, hey, I have this portacath, it needs this length needle. Little things like that, because it just creates so much drama. And you always feel terrible, particularly for the younger kids. They just, they're being held down, and it's taking multiple attempts to stick them, and just the amount of emotional trauma that happens. And so you don't want them to fear seeking medical care, and maybe sort of saying, well, I feel like it's okay, I don't really want to go to the emergency room. So you want them to be able to feel comfortable. I got to go there, not say, I don't want to go there, I'm going to try to find an excuse to say I'm fine, and maybe I can just wait till tomorrow. Because that's what I worry that sometimes happens, is they want to avoid the emergency room, and then they wait on a bleeding event, and it becomes much more difficult to manage.
I guess as a follow-up on that, we've heard directly from patients, in some instances, patients of color, that they have been discriminated against in emergency rooms. And I guess, in this, aspect of you both talking about advocacy and trust, and, wanting to not have trust in one aspect of the healthcare system affect kind of treatment in every aspect of the healthcare system. How do you address that, whether that's implicit bias or direct bias for, underserved community patients?
Yeah, that's tough. We always try. It's going to be difficult, right? You're going to have, anytime you go somewhere, you might have 7 really good experiences, but you're mostly going to remember the 1 or 2 really terrible negative experiences. And so when they do have those experiences, we often tell, we ask them to tell us the next day. I often will, call down and, find out who the person that interacted with them, ask them, hey, it seemed like that was a rough interaction, what was happening, because it's hard, because you don't want to come after that person without knowing what's going on, because sometimes it could be, they could say, oh, the family was yelling at me the whole time or something. And so you try to do that, and so you call them next day, maybe when it's less, and try to be not as confrontational, because I think you have to sort of address the people that are interacting with them and say, hey, it was a really bad experience for them. They just didn't feel like you guys were listening. And so I think if you approach it that way, very non-confrontational, and I said, you can tell them, I get it, it's busy, it's 3 a.m, you guys are tired. I know you're dealing with all kinds of stuff. So at least they understand, this probably, you could have done this, or this would have probably helped the situation better. So you have to have those really, the part of it is those uncomfortable conversations, right? Nobody wants to be confronted and be told that something they did wasn't great, and particularly people in our field. Lots of high achievers, they feel like everything they do is great. They never do anything terrible. And so it's really hard to hear, like, I didn't do something really good at that moment. Doesn't mean I'm a bad person, but I need to be better. So I just, you have to call people out on it and hope that they hear it and they move on, and maybe the next time it'll be better. So it is tough, though,
The other piece of that, and I agree that it's important for when we're aware that these things have happened, that we don't just accept it. Something needs to happen. The other piece of it is to acknowledge with the person who experienced it that wasn't good. Like it just wasn't good. That's not what anybody wanted for you. Can't always prevent that from happening, but what I can do is advocate for you, and just validate that, like, you know, the healthcare system sometimes just doesn't work, and a lot of that has baked into it things that are really unfair and just not right and unjust, and hopefully that we can say, like, yeah, the trust may be broken with that particular. We certainly have people that are like, I never want to go back to that year again, and I can say, I totally get it. If you're having a life-threatening thing, I want you to live. Yeah. But it's valid to never want to go back. Yeah. So we gotta have that. It's a really hard conversation.
And do you feel like, you know, so much of this conversation today about clinical trial enrollment and research has been about the trust of the provider, that communication, that relationship has been a big word. Do you ever feel like threatened, or not threatened, but do you ever feel anxious about emergency room visits in that context? If a patient has a bad experience, that maybe, you know, that will impact your treatment?
Yeah, I mean, you always worry about that. I mean, we have patients that have lots of negative experiences. They might have met a provider they didn't like, or you know, they were admitted for something and they had bad interaction with the nurse or somebody, or maybe the phlebotomist was not patient enough and caused a lot of chaos. And so, you know, it's tough because we often will have to go in and say, yeah, I'm sorry, you have to validate it. It's like, you know, that sucks. You know, certainly people aren't here to try to do, you know, people are generally trying to do the right thing, but you got a lot of human beings involved, and some people, you know, they might be having a bad day, they might have just, you know, just been a cranky person. And sometimes there are people that just, you know, need to be removed from the system, obviously, like that. If it happens often, you just have to make sure that you notify people, that it isn't just like, you know, say, oh, well, that sucks, and then don't do anything about it. Because it could be the same person that's doing it to lots of different people, and it needs to be corrected. So, but you do worry that, you know, you have a lot of these negative experiences, and so you're going to lose the trust of these patients. But I think if you're extremely honest with the families and tell them, yeah, that sucked, that wasn't appropriate, that, you know, wasn't right, you know, that's really obnoxious, and just say, you know, we're just trying to make sure that doesn't happen again, you know, for you and for somebody else. I think it's good. You need to show that you're actually doing something instead of just listening and then walking out and never addressing it. So I think that's really important. Patients see that if you're very direct and honest. I think they acknowledge and understand that. So, because they know that you can't control everything that happens in the hospital. So,
100%.
I agree. And also, medical trauma happens anywhere you get medical care. So it's not just in emergency rooms, and it happens in HTCs too. So I think we need to acknowledge it's everywhere in the system at every level, and it happens for lots of reasons. And the main thing is to find providers that the patient will trust, and other providers that we as providers will trust. And then with regards to research, a lot of research doesn't really happen in emergency departments. Hopefully it's because that's not really where, other than implementation science, maybe that's not where the big questions are happening. It's around treatment decisions and efficacy and things like that. The ER may be the result of something that didn't go right in a treatment, but isn't like the main event. And another thing that I think is a real challenge to identifying problems and getting adequate care is the normalization of what is abnormal bleeding, even by someone who's living with it. So like you get into a setting where you need care and it's like, how's your bleeding? Well, it's not too bad. It's actually quite bad because you know you don't want it to be bad, and you want to have a good life and a normal life. So that comes back to like what's education around normal and abnormal, and self-advocacy, and hopefully the system around you. And but I haven't found a way to prevent medical trauma, only to try and support through it.
Well, I guess the point, you know, and where the health equity comes in is when medical trauma comes as a result of, you know, minority status or underserved community status. And that's where this, you know, these conversations, when it comes to solutions, when it comes to defining the issue, that systemic reason of, you know, yes, medical trauma happens to everyone, but what if it happens to you repeatedly every time?
It doesn't happen. It happens to everyone, but it doesn't happen equally to everyone. And that is something that it's such a big problem. It's more than the bleeding disorder community. I think the solutions to that have to be you're never going to get everyone on the boat, but we got to get as many people on this boat as possible to say we need to be addressing the inequalities in the system, because everyone deserves healthcare. Everyone deserves healthcare.
Yeah, and it's you know, and it takes patients mentioning it, speaking about it to us, and it's uncomfortable at times because you feel like, man, I feel like we're doing really well and doing our best. But you have to just sort of be able to take a step back and look at what you're doing as a hemophilia treatment center, as a group, and say, you know, we could be doing better. Just because we're doing great in some of these other things doesn't mean we're doing perfect. And we're all trying to get better at everything, right? And so we need to get better at that as well, not just, you know, we should feel good that we're taking care of our patients medically, but there's always things that we could do better. And, you know, the centers need to advance and change over time, or it's just not going to be adequate. And just saying, you know, it's great, we're doing great, our enrollment in this is great, but we have to look at some of those other things that maybe we don't always measure, so.
I think that's an opportunity for the member organizations too. Like, I think it makes sense that you wouldn't always want to come with that bad thing that happened to tell that system that was part of what did that bad thing to you. So that's maybe another safe space where we can do communication where the burden isn't so much on each person. It's a lot to ask someone who's been traumatized to then come and advocate for that trauma over and over again. So there's got to be it's a multi-pronged approach.
Yeah.
Thank you so much. And you know, looking now you know, into the second panel on emergency room facilities and HCC communication. You know, previously we were talking about, you know, what you can do with member organizations to help reach, you know, diverse communities, and we talked about how you know, meeting people where they are. Unfortunately, you know, I think, you know, in between sessions, Jill raised the point that not every HTC is built the same, and not every individual patient has the same needs. And I think it's incredibly important when talking about the issue of emergency room facilities and access to care. You know, as you know, many hemophilia patients receive a lot of their care through emergency room settings for, you know, bleeds when they arise, compared to, say, an HTC, you know, which they may visit once a year or periodically. I'd like to discuss the role that emergency rooms have in the healthcare system and how we can dive into that communication and function to better improve the access to care and in clinical trial enrollment for underserved communities. Looking at these questions, there's a lack of communication and transfer between ERs and HCCs for patients who are seeking their care primarily at emergency rooms, leading them to not have the same opportunities to enroll in clinical trials or research. This we know, emergency rooms aren't a setting for clinical trial enrollment, they're a setting for emergency treatment. Yet for patients who have the primary, you know, care for emergency bleeds, or who may only be going to emergency rooms to treat their bleeding disorder, emergency rooms may be the primary healthcare system that they see. Looking at that, how important is a well-regulated patient intake system or communication between facilities for the overall health outcomes of a bleeding disorder patient? I know that's a pretty weighty question, and you know, diving into it, the answer might just be a lot, right?
Well, you know, emergency rooms is tough.
Yeah.
Right? So, because emergency rooms, that's a place they see everybody. You know, they're seeing trauma patients, they're seeing stroke patients, they're seeing heart attack patients, they're seeing minor trauma patients. And so, yes, do our patients who have rare disorders, bleeding disorders, do we have them interface, and do they have to interface with emergency rooms across the country? Yes. Are there some patients who are in situations where maybe they don't have care on a regular basis? They're not plugged in with an HTC, and so they're utilizing emergency rooms. Unfortunately, that exists too. But emergency rooms can be a really tough place to have a kind of cohesive relationship and a streamline of communication, because there's often a lot of turnover in the emergency rooms. They're managed in a very different way. There's a lot of turnover in terms of they're working 12-hour shifts. You know, they're working 8-hour shifts. I've tried to tackle emergency rooms, you know, both at the medical school and in the community, in a number of different ways, for a number of different reasons. And sometimes protocols work to try to put something in place so that if we have a patient who enters the system in an emergency room or who's a frequent utilizer of emergency room services, we'll have a way to know who that patient is and plug them back into our system, or say, hey, the HTC is available, hey, this doctor's available, hey, this service is available. If you're going to the emergency room, try to make sure those emergency room doctors can connect them. There are some people who have it down to a science, but I think it's tough. So I think the best way that at least I've tackled this has been to try to empower the patients, right? When we see the patients, to empower them to communicate with us, to empower them to know what to do when they go to an emergency room. And then ultimately we will have more patients that we can educate about clinical trials, like on the back end of that. But emergency rooms are tough.
Yeah, I agree. Emergency rooms are tough, and it's because there's different types of emergency rooms in different settings, and there's different needs to go to an emergency room, or the emergency department, or an urgent care, or some setting that's not a setting that's set up for bleeding disorders. As with all the other answers, it's a really individual need. So I can speak to a couple like situations that I might illustrate. The most important thing is that the person who's living with the bleeding disorder knows what their bleeding disorder is and what's the proper treatment for it, and that someone else also knows, so that if they cannot speak for themselves, they have an advocate. And when I have a patient of mine, we're working on that education, and we're also working on someone needs to let us know you're going to the ER.
That's right.
Because it is also our job to be your advocate, to explain to the emergency room physician who may have never seen the disorder that you've got, what is the care need. And also to help advise, is the ER the right place for the thing that's happening? Because, or is the ER you're going to the right one for this context? Or is that a place we're gonna have to cab factor to, but if you had an equal choice, there's factor at this other one. So it's a guidance of care. The ER as a setting for research is a slightly tricky thing. I think we want to capture in research what's happening in emergency settings, but it's not the primary point of entry into research.
No, and even it's complicated because insurance claims aren't even included in emergency room entrance is not included in standard insurance claims, which makes a large basis of research. If we're looking at, like large data analysis, that is not accounting for emergency room visits because if it's looking at insurance claims, it's not looking at emergency room visits, which,
Yeah, it just, emergency rooms are tough. I think probably the streamlined answer is we have to empower patients to have a plan.
Yes.
Right, to understand all emergency rooms are not created equal when you have a bleeding disorder. Try to have a plan which emergency rooms you're going to utilize, and to have your script ready.
Yes.
Right, like this is what I have, this is what I take, this is my physician, and if you have the ability to contact your HTC through the on-call service before to do that. But that can be a tough one. Tackling emergency room.
Especially because of turnover.
Turnover is high. Electronic medical record has made it better. So if you can communicate within the same system or communicate across systems, and you can at least see what happened in the emergency room, or the emergency room can look back and see, your notes and what you're saying, that can help. I'm sure that in theory is what we envisioned, would happen with electronic medical record. We're not quite there. But I think empowering patients and advocates within families to know what the plan will be, where should you go, and if you end up having to go to an emergency room and it's not an ideal setting, to have a plan for that too.
Good communication is the key. We certainly, so in my state, almost none of them are in the system where our medical records are, so it's all about communication. And the other thing is that it really depends. So I have patients in very rural communities, that may also be the infusion room. So it
That's
sort
right.
of depends on what's the need. It is definitely, I think we need more evidence around to say like, which parts of healthcare utilization are being used and which ones of those could be better.
Yes, 100%. Thank you so much for that.
And that's it. That's the whole event. We're really happy that everyone was able to join us today for this. If there's any final questions or if anyone would like to say anything now, it's a good time. Thank you so much for everyone that stayed on until the very end. Unfortunately, due to technical difficulties, we ran over a little bit, but I can't wait to see everyone here for day 2 and day 3. Again, that will be day 2 will be next week, Tuesday, the 19th, and then day 3 will be the 26th. Day 2 will focus on community organizations and how HCCs and community organizations can work together to reach underserved communities. And day 3 will be a working group that will connect everyone to come up with solutions and how we can reach underserved communities, how we can better provide care and services and work together. The rest of the sessions will only be 2 hours, with the last session being 1 hour and 30 minutes. This one ran about 3 hours just due to those technical difficulties, but day 2 will just be a Zoom meeting. So it won't have any pre-tapes. There won't be any need to run anything through. It will just be like this with a spotlight and opportunities for questions. Thank you so much. Well, if that's it, I'd love to let you out before 6 p.m. Have a great day, everyone. Bye.